Good morning, everyone. Welcome to the 6th International Health Science Conference, Anesthesiology and Intensive Therapy session. My name is Dovilė Banaitytė, and I will be leading this session today. First of all, on the behalf of the Students' Scientific Society of Lithuanian University of Health Sciences, I would like to thank our patrons, Frasenijos Krabi, Roche, Medita, Origmet, and others, for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that this conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientists all over the world. Additionally, I would like to express gratitude for all of the reviewers and today's jury. Please welcome Tomas Bukauskas, Professor Andrius Pranskūnas, Professor Kęstutis Remaitis, and Marius Remaitis. We kindly ask jury members to remain at the session until the points are counting and the winner is announced. Before starting the session, I would like to remind you some rules. Today we will hear 8 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the session. The winner will get great sponsored awards, gifts from Bioderma, Sapiens, Chrysostomos Bookstore, Origmet, Gintarinė vaistinė, Fieldman, and Medita. Winners will receive their gifts after the session. Moreover, presentations should last no more than 7 minutes. After that, 3 minutes will be dedicated for questions from the jury members and listeners. Please note that if your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit the given time frame as well. Moreover, each presenter will receive a certificate that will be sent to the emails after the conference. Do you have any questions before we start?
We have no questions, but we have comments. Can we?
Yes, of course.
So?
Yes. Yes, of course.
Good morning, dear friends. Good morning, students. And it's very nice to meet you here in this conference. Here we are not so many at the moment, yes? But I think here there are these students who are really real. And I'm very happy. I'm not a jury, but I will be just like an auditor or observer. And it's a great pleasure for me to be in this position. And I am very thankful Professor Kęstutis, Professor Andrius, Doctor of Sciences Tomas, Doctor of Sciences Marius. They are really not nice, but not even clever. They are nice and clever. But they are very warm teachers of our university, and I think they are face of our university. So thank you, jury, thank you, Dovilė, and good luck for all of you. Thank you very much.
Thank you very much for your speech, and best of luck to all the presenting authors. So now I would like to invite the first presenter, Monika Kropaitytė, to give us the first presentation, Comparison of Status Epilepticus Scoring Scales for Predicting Mortality in Neurosurgical Intensive Care Unit.
Good morning, everyone. My name is Monika. I'm a 6th-year medical student, and today I will talk about our study comparing status epilepticus scoring scales for predicting mortality in neurosurgical intensive care unit. So status epilepticus is a neurological emergency that is defined by 2 time points. The first one defining a prolonged seizure, and the second one defining the development of potential long-term consequences. And the mortality of this condition is quite high. It reaches up to 39%, making it the second deadliest neurological emergency. And so because of that, over the recent years, a couple of scales have been developed in order to try and predict a high-risk patient. And amongst the most popular ones are Status Epilepticus Severity Score, or STESS, and Epidemiology-Based Mortality Score in Status Epilepticus, or EMSI. And so the aim of our study was to determine the value of these 2 prognostic tools, STESS and EMSI-EAC, for predicting mortality after Status Epilepticus. And in order to do that, we conducted a single-center retrospective chart study of neurosurgical ICU patients. We included the patients that experienced status epilepticus and were 18 or older in age. And in total, 47 patients fit with those criteria. So then we proceeded to collect the necessary information in order to score our patients. So the first scale is EMSI-EAC. So E stands for etiology, and we scored the one that suits best for the patient. Then A is for age, and C is for comorbidities. And in terms of comorbidities, we had to score every single comorbidity that the patient has, not just the one that would score highest. Now, STESS scoring system is a little bit more simple. It scores on 4 criteria, so consciousness, worst seizure type, age, and history of previous seizures. And a score of 2 or higher, according to the creators of the scale, is considered to identify a high-risk patient. And the maximum score for this scale is 6 points. We performed our statistical analysis using IBM SPSS statistics, and we used the receiver operating characteristics and the chi-square to determine the relationship between variables as well as the area under curve. Now let's take a look at the results. So you can see in this table here that the average age of our patients was 50.74 years, though it did range from 20 to 82. Slightly more than half of those patients were males, and 52% of the patients had previous history of seizures. The vast majority of the patients experienced generalized convulsive seizures, and the in-hospital mortality was quite low, as only 4 patients didn't survive status epilepticus, so that added up to 8.5%. In terms of etiology, you can see in this chart here that the range of etiologies is quite wide, though over a third of our patients had cryptogenic etiology, meaning that we couldn't determine the reason for their status epilepticus from the data that was available. And in the second place, there is a confirmed low anti-epileptic drug concentration. In the third place, there is traumatic brain injury. So after we scored our patients on EMSI scale, we proceeded to calculate area under curve, which in this case was 0.881. This result was statistically significant, so we started to look for optimal cutoff point. Whilst the mean score was 21.36, it ranged from 3 to 83, and so we chose the optimal cutoff point at 34, at which sensitivity of the scale is 100%, specificity is 83.7, and positive predictive value is 100%, and negative predictive value is 36.36. So this scale turned out to be good for predicting better outcomes rather than bad ones. Now let's review the STESS scale. So in order to do that properly, I have to show you this table here that shows the distribution of STESS scores. You can see that only 21% of the patients scored less than 2 points, and that makes the majority of the patients to be a high-risk patient. And that doesn't necessarily correlate with our mortality rate, which was only 8.5%. And this point is further proven by this area under curve you see here. It was only 0.677, and this result was not statistically significant. And this is something that this problem could be called a ceiling effect. And in this case, that means that too many patients score a significant amount of points, and that doesn't correlate with the mortality of the patients. Thus, the 2-point margin is too low to accurately predict a high mortality risk. Now, our study, they have some limitations. First one, that it's done retrospectively and uses the existing data that has been collected for other reasons than this research. Our sample size was relatively small, so it may not be as reflective of an entire status epilepticus patient population. But to conclude, neither MCEAC nor STES were accurate enough to predict in-hospital mortality. Technically, MC scale could be used to determine patients with better prognosis, but it's slightly too complicated to be used in daily practice, and STES scale is not accurate enough to be used in daily practice, at least in our case. So, thank you all. I am now looking for your questions. I'm not sure whether they were appropriate. I guess because I used them, so I decided that they would be appropriate for the study. Maybe they would be better for a larger sample size.
I would like to interrupt. Can you use a microphone when speaking, please? Thank you.
Hello, thank you for a nice presentation. And one question, what is practical implementation of this study in the practice? What scale used at this moment in the Department of Neurosurgical?
So neither of those scales are used currently in the neurosurgical ICU, and the aim of the study was to evaluate whether they could be used in the NICU. But as we can see from the results, it is slightly too complicated to be used in daily practice and probably shouldn't be used because it doesn't really add any additional value and it doesn't really change the course of treatment for the patients.
But at this moment, what scale is used in this department?
In which department?
In neurosurgical department.
None of them are used.
Oh. Thank you.
Thank you.
I wanted to ask you to clarify what's your contribution by yourself, what parts of the study you did.
I collected the data of these patients and performed statistical analysis as well as analyzed the literature regarding it. And Dr. Neringa Balčiūnienė consulted me on every single one of those questions.
So you did the scoring?
Yes, yes. Okay, thank you.
So thank you for your presentation and for your questions. And now I would like to invite the second presenter, Barbora Stankevičiūtė, to give us the presentation monitoring the implementation of the surgery safety checklist.
So, good morning, everyone. My name is Barbora Stankevičiūtė, and I'm a sixth-year medicine student of Lithuanian University of Health Sciences. Today, it is my pleasure to present to you two studies that I've prepared with my colleagues. So, first of all, I would like to start with our study on monitoring the implementation of the surgical safety checklist. Firstly, I would like to thank our colleagues student Goda Aldakauskaitė, anesthesiologist Vilma Traškaitė-Juškevičienė, and professor, the head of anesthesiology department, Andrius Matsas, for their help and input during this research. So, in 2009, the surgical safety checklist, consisting of 3 parts, sign in, time out, and sign out, was first introduced by the World Health Organization. Nowadays, it is used globally to ensure patient safety during the perioperative period. Since the checklist was launched, mortality, surgical site infections, and post-operative complications have decreased by approximately 50%. Nevertheless, for successful implementation, it is crucial to have the whole operating room engaged in the adherence to the checklist. In 2020, the SSC was adapted in the Hospital of Lithuanian University of Health Sciences Kaunas Clinics. The aim of this study was to evaluate the accuracy of use of the checklist 1 year after its implementation in the Hospital of LUHS Kaunas Clinics. The data for this observational study was collected from November 1st to December 31st, 2021. Data was gathered by independent, non-biased, concealed observers via objective monitoring of all 3 checklist components taking place in ORs. The data was gathered in urology, general surgery, and ear, nose, and throat diseases departments. Statistical analysis of the data was performed using the IBM SPSS Statistics 22 software package, and a significance level of 0.05 was chosen to test statistical hypotheses. During the 2-month period, 69 surgeries were observed, 25 in general surgery, 23 in ENT, and 21 in urology, as you can see on this pie chart on the right. In only 3% of the operations, use of the entire checklist was observed. In 21, use of only separate parts, and in 76%, no parts of it was applied. The age of the surgeon and the anesthesiologist did not have any significant importance on the adherence to the SSC. The use of the checklist during the sign-in section, which is the first part of the checklist, was more common in the urology department, while adherence to the protocol during the timeout section, which is the second part of the checklist, was better in general surgery department. Questions regarding antibiotic administration, around 28%, surgical site, around 25%, the duration of operations, around 23%, and blood loss, around 22%, were most frequently asked questions and confirmed by the surgical team. However, the least prevalent questions included the risk of hypothermia, the use of pulse oximetry, and presence of the consent forms. The overall implementation of the checklist was extremely poor, with ENT adhering to it the worst, with only 2 sign-in and 1 timeout conversations in 23 surgeries observed in their department. So, to conclude, despite the many benefits the VHO's surgical safety checklist offers, compliance with it in Kaunas clinics remains incomplete. To achieve better adherence to the checklist, it is crucial to promote engagement of the whole surgical team. So, thank you for your attention. Do you maybe have any questions?
Thank you very much for your presentation. I have one question. How do you think how this checklist could be improved?
I think there are a couple of points that could help to improve the checklist and the adherence to it. First of all, there is a possibility for every specialty clinic to adapt the checklist to their needs, so it can be done. Also, I think the importance of the checklist should be stressed more, and maybe some kind of educational courses should be taught.
Okay, thank you. Thank you for your answer.
Thank you for your presentation, but for me it's very interesting. What do you think how this checklist can improve the results? Because in your abstract I saw one literature about improvement of surgical results and about 50% less complications when this checklist was introduced. So in this study you have a very low level of patients because it's 69 surgeries. It's very, very low to compare with it was introduced for 1 year already. What is your opinion about that?
So our study, of course, had limitations. We collected data only for a month's period, so we only had a limited period of time to get as many operations as we could. The number 50% that it reduces complications, this is taken from WHO's statistics. I mean, there are questions in the checklist about antibiotic use, about surgical site that helps reduce the risk of infections, that help to check on the operation site, because there are a couple of instances where the wrong site of a body is operated.
And it's like comment or question, I don't know, but actually the results of your study showed that introducing of this checklist has a very low impact on patient results.
We didn't research the impacts on patient results. We only research how the doctors are adhering and taking part in doing the protocol and asking the questions and implementing the surgery safety checklist.
I'm sorry to interrupt, but the time is over. Thank you for your presentation. Thank you for your questions. So Barbora will give us another presentation called Nutritional Assessment of Critically Ill Patients in the NICU according to the ESPEN guidelines.
So hello again. Another study I would like to present is on nutritional assessment of critically ill patients in the NICU according to ESPN guidelines. Once again, I would like to thank my co-authors, Goda Aldakauskaitė and Doctor of Intensive Care, Neringa Balčiūnienė, for their help and input during this research. Critically ill patients, especially those with an acute neurologic injury, are in higher risk of malnutrition because of a hypermetabolic state which results in an excessive release of stress hormones and pro-inflammatory cytokines that alter energy and protein metabolism, which eventually leads to malnutrition. Malnutrition in itself is associated with adverse clinical outcomes, therefore the proper nutritional support is essential for these patients. The aim of the study was to analyze the nutrition support of enterally fed patients admitted to the neurosurgery intensive care unit of the Hospital of Lithuanian University of Health Sciences, Kaunas Clinics, and to compare according to the latest European Society for Clinical Nutrition and Metabolism, otherwise known as ESPN guidelines. So the data for this observational study was collected from November 10th to December 10th, 2021. Data was gathered by independent, non-biased, concealed observers via objective information collection from prescriptions. all patients who spent more than 24 hours in the NICU on enteral nutrition were included in the study. Nutritional needs were assessed using VCO2 parameter when possible, and if not, a formula of 20 to 25 calories per kilogram. And adjusted body weight was used for patients with a BMI over 30. The results were then compared with the ESPN guidelines for clinical nutrition in the intensive care unit. Statistical analysis of the data was performed using the IBM SPSS Statistics 22 software package. The chi-square test was used to determine the relationship between variables. A significance level of 0.05 was chosen to test statistical hypotheses. The nutrition of 26 patients, 19 men and 7 women with a mean age of 66.08 was assessed. The patient's mean BMI was 27.43. 11 patients were hospitalized after a stroke, 11 after brain trauma, 2 had a neuroinfection, and 2 had other diagnoses. The average time to start feeding was 2 days. But for 3 patients, nutritional therapy didn't start until day 3 or later, and the reasons why remained unclear. Caloric needs were met in around 73% of patients, and protein needs in around 77%. Caloric needs were met in approximately 3.89 days, and protein needs in around 5.05. But only around 62% of patients reached their caloric intake within the recommended period of 7 days. Patients with a BMI of 25 to 29.99, or in other words, overweight patients, were more likely to not reach their caloric needs and to have their calorie and protein requirements calculated according to ideal or adjusted body weight instead of normal body weight. So, to conclude, for most of the NICU patients, enteral feeding was started according to ESPN guidelines. For the majority of the patients, their caloric intake and protein requirements were reached. The overweight patients were at a higher risk for malnutrition. So, thank you for your attention. Do you have any questions?
Thank you for an interesting presentation. And one question, what is the hypothesis of this study?
The hypothesis was that the patients of NICU were undernourished, and yeah, we wanted to test that if they were.
It's a very interesting presentation. I wanted to ask, as your results show, so does that mean that patient of my constitution is condemned for starving in neurosurgery ICU?
I wouldn't say starving, but I mean, there are some gaps in the education on how patients should be nourished in the ICU, and the patients who have a little extra weight are those who have been misnourished the most, if I can say so.
Because some studies shows that hypocaloric diet is sometimes is better than normal caloric diet. It's a very difficult question.
Yes.
Thank you. Thank you.
One small question about statistical analysis. You report means, while the number of patients you studied was very low. So did all the variables meet the criteria for normality? Did you check that?
Yeah, they did.
So thank you for your presentations and thanks for your questions. And now I would like to invite Mante Eidininkiene to give us the presentation Pre-Anesthetic Evaluation and Non-Cardiac Surgery Experience at Kaunas Clinics.
Good morning, everyone. My name is Mante Eidininkiene, and today I would like to present our research, which was guided together with my colleagues, pre-anesthetic evaluation and non-cardiac surgery experience at Kaunas Clinics. But before that, I would like to thank to our mentor, Professor Andrius Macas, for giving us an opportunity to accomplish this research and for his help. I believe that we all know how important and inseparable part of anesthesiologist's daily practice is pre-anesthetic evaluation. There are numerous of recent studies that shows different opinions about preoperative assessment, but current guidelines and expert opinions encourage specific testing in selected patients, especially the ones with comorbidities. There are some tools and tests that helps us to anticipate the possible risks and to anticipate the possible risks and to prepare an appropriate anesthesia plan. Using revised cardiac risk index, which was used in this study, score when evaluating cardiac risk is a recommended sign of good anesthesia practice, and the revised cardiac risk index is acknowledged to be the most validated clinical risk index. So we share our findings and local experience with patients undergoing non-cardiac surgeries. The aim of this study was to investigate pre-anesthetic evaluation possibilities based on the patient's laboratory and instrumental tests available on a day of hospitalization. After the approval for this retrospective research, which was conducted from June 2021 to September 2021, we included the inclusion criteria where patients older than 18 years old, planned non-cardiac operation, and the data was collected from the personalized medical documentation of 117 patients who were hospitalized at the Hospital of Lithuanian University of Health Sciences, Department of Surgery. The gathered data includes sex, age, comorbidities, operation type, ASA score, revised cardiac risk index, and both laboratory and instrumental tests. These tests involve general and biochemical blood tests, coagulation panels, electrocardiograms, and others. And here you can see the revised cardiac risk index with its 6 major variables. And for example, if the patient has 3 or more predictors, it means that he has an 11% of probability that the cardiac event can happen during the surgery, or cardiac complications can happen during the next 6 months. And here are the results. The study involved 117 patients, 27.4% of men and 72.6% of women. The average age of the patients was 53 years, and the youngest patient being 19 years old and the oldest 79 years old. The majority of the patients were multimorbid, and 71.8% of them had 2 or more comorbidities. And here in this pie chart, you can see that the most frequent comorbidities were in cardiovascular and endocrine systems. The mean of the ASA score was 1.97, whereas cardiac risk index mean was 1.12. Only 57% of the patients had their ECG on a day when operation was scheduled. 64% of them had general, and 62% of them had biochemical blood tests. The most common additional test was coagulation panel, and you can see that 33.6% of the patients had it prior to surgery. The stomach reduction surgery was performed in most cases, and hernia repair takes second place in frequency. 25 patients had 2 or more cardiac risk index points. 15 individuals were assessed having 2 points, 14 of them had ECG, and 11 of them had additional tests on a day of hospitalization. 9 patients were evaluated having 3 RCRI points, but only 3 of them had ECG and additional tests. Only 1 patient was evaluated for 4 RCRI points. He had ECG, but no additional tests done. And the most important finding in our study was that 72% of patients who were at increased risk, according to RCRI, had ECG when they came for surgical treatment. So to conclude our research, the majority of the patients with a higher cardiac risk, according to revised cardiac risk index score, present ECG for their pre-anesthetic evaluation. Unfortunately, no significant associations were found between patients' ASA or RCRI scores and preoperative tests. Thank you for your attention, and I'll be delighted to answer your questions.
Thank you for your presentation. I have one question. How could you comment your conclusions? I mean, how do you think why there is no relationships, associations between scores and tests? How do you think?
I think that maybe with bigger sample size, larger sample size, there would be some correlations between these ACA or revised cardiac risk index scores, I believe.
I have one question. As I saw in your study, most of the patients actually were relatively young patients. And if you want to test correlation about the impact of or prognostic value, it is better to take into your study to include patients of cardiac comorbidities and standardized surgery, because you know, if you have surgery in ENT department or you have a major abdominal surgery, it's not the same.
Thank you, and I agree with your opinion.
One practical question, and I would like to hear your comment. You know, it's quite strange to me to hear that there are very, well, relatively low rates of full preoperative laboratory analysis in patients which are undergoing elective surgery, as I understood. So could you comment how you checked for those test results, whether it was from hospital database, or did you check also tests which were done on ambulatory basis, because many of elective patients come with tests already performed in other institutions.
Thank you for a question. And the main point of this study was actually not to check the data in databases, but to check the paper ones, medical histories. So we checked all the patients' medical histories, which were the paper ones. So we searched for those laboratory tests in these histories, and maybe that is because this percent is not as high as it should be, I guess.
So you did not check the electronic database of the hospital?
Only the medical histories in paper.
Okay, thank you.
I'm sorry to interrupt, but the time is over. Thank you for your questions. Thank you for your presentation. Mante will give us another presentation. It is called The Value of Suprainguinal Fascia Iliaca Blockade for the Treatment of Postoperative Pain After Primary Hip Replacement Surgery, a pilot study.
Hello once again, and now I would like to present a pilot study about the value of suprainguinal fascia iliaca blockade for the treatment of postoperative pain after primary hip replacement surgery. And I would like to thank to my fellow Goda and to our supervisor, Dr. Arūnas Gelmanas, for providing us an opportunity and for giving us knowledge and help for this research. Hip replacement surgery is a common and painful surgery with moderate to severe pain in the postoperative period, despite the multimodal analgesia. Recent studies have demonstrated that peripheral regional blocks like suprainguinal fascia iliaca blockade might be a preferable procedure for pain management after hip replacement surgery and may reduce the amount of consumed painkillers. The adequate pain management is an essential thing after major orthopedic surgeries because of the aim to speed up rehabilitation and to shorten the hospital stays. However, the role of this suprainguinal fascia iliaca blockade for postoperative analgesia after this type of surgery remains questionable. So we share our pilot study research with patients undergoing primary hip replacement surgery. The aim of the study was to evaluate the effectiveness of pain relief after primary hip replacement surgery using suprainguinal fascia iliaca blockade. The approval for the research was granted by our University Biomedical Research Ethics Committee, and double-blinded randomized pilot study was conducted at the Clinic of Anesthesiology in Kaunas clinics. Preoperatively, patients were blindly randomized in two groups, suprainguinal fascia iliaca blockade group and control group. Neither the patient nor the independent investigator were not informed whether they received the blockade or not. Evaluation of pain at 3, 6, 24, and 48 hours postoperatively, patients were assessed for subjective hip pain using a visual analog scale and the location of pain on the operated leg at rest in active and passive 45 degrees flexion positions. The need for additional painkillers has been reported. And here you can see a tool that we used in this research, the visual analog scale, where the patients marked their pain score. And here are the results. 10 patients were examined, 9 men and 1 woman. The mean of age was 65.5, where the youngest was 44 and the oldest 85 years old. The mean of ASA was 1.8 and body mass index mean was 27.67. and you can see that the majority of the patients were overweighted. Unfortunately, no statistical significance was found in the suprainguinal fascia iliaca blockade group compared with the control group in terms of pain at 3, 6, and 24 hours after surgery. 48 hours postoperatively, pain in the passive and active 45 degrees flexion was lower in the blockade group than in the control group. In the passive 45 degrees flexion position, average visual analog scale pain score was 2.1. The mean pain score was 1.8 with blockade and 2.4 without block. These findings were not significantly associated. In the active 45 degrees flexion position, the mean of pain was described 2.2 by visual analog scale. Blockade group had a mean pain score of 1.8, while in the control group, the average pain score was 2.6. Unfortunately, no strong correlation was observed between these groups. Furthermore, 48 hours postoperatively, 50% of the individuals received additional painkillers, of which 40% in the blockade group and 60% in the control group. So to conclude our research, our collected data suggests that postoperative pain management with suprainguinal fascia iliaca blockade may be valuable after hip replacement surgery. However, a larger study involving more individuals is needed to make the data more reliable. Thank you for your attention, and I'm waiting for questions.
Thank you very much. It's a nice presentation, and it's a very good quality study design, but the sample size is very small, so it is very difficult to make some conclusions in such a small study, but it is pilot study. In your results, you are showing some difference in VAS score, but actually clinically 1.8 and 2.6 is not a very big difference. It can be statistically significant, but actually it is not significant clinically. So can you comment with? And one more thing is very important, that you are comparing categorical values using statistical analysis of t-test. But categorical values has to be analyzed using non-parametric methods, such like Mann-Whitney U-test.
Thank you for your comments. And yes, it is a pilot study, and I hope that in the future we, with our supervisor, we will present the larger sample size, and the statistical analysis will be should be with a visual analog scale and non-parametrical sizes. But another comment about the visual analog scale is that this is a subjective opinion of the patients, so I guess it's really hard actually to know it's it is hard to understand the actual pain, because our pain is by pain levels is really different. So I guess this is actually important to notice that.
Pain is subjective sensation.
Yes, yes.
And it is very difficult to make comparisons about that. So we are using visual analog scale, that is categorical values, and you can, if you use right, appropriate statistical analysis, you may get some differences, maybe more or maybe less.
Thank you.
one question about analgetics. Which or what analgetics receive patient in the control group during evaluation period?
During the evaluation period, we observed the all analgetics that were for them, including the opioids, including the non-inflammatory analgetics, and we included all of them.
In the control group, yes.
In both groups.
In both.
Yes, yes. Because in the blockade group, there were also some individuals that they had their needs for these analgetics as well.
And you compare those of these
Yes.
energetics.
Yes.
And you show?
In the future studies, we will maybe present the more reliable data about that.
Okay, thank you.
What's your contribution in this study?
I was the one that collected the data. I was going to the patients and I was asking the questions about their pain and doing the flexion, the passive flexion, for example, and I was collecting all the data and going at 3, 6, 24, and 48 hours postoperatively.
Thank you for your wonderful presentations and for your questions. And now I would like to invite Yelena Tsarskaya, and she will give us the presentation, Should Healthy Individuals Be Considered as Non-Fluid Respondents?
So good day, everyone. Such a nice event with all the female presenters at this section. So I guess well done, ladies. So my name is Yelena Tsarskaya. I'm here with my colleague Mante Indinikiene, whom you just met, and together with our scientific supervisor and the main inspirator behind all of this, Professor Andrius Pranskūnas, we designed and conducted a pilot study in order to check our hypothesis: should healthy individuals be considered as non-fluid responders? And to do that, we used a well-known method in the practice of intensive care, which is called passive leg raising. So passive leg raising test has been developed to help predict whether volume expansion will significantly increase a patient's cardiac output and improve overall hemodynamics. As I mentioned, in critical care, evaluating a patient's fluid responsiveness by observing those cardiac output changes using this test is a safe, common, and reasonable practice. So if we have a patient who is in septic shock, who is hypovolemic, a physician can perform a PLR test on the patient and check if the patient is the fluid responder. If he is, then the fluids can be administered, and afterwards you can repeat the test again, and basically this can go on until the patient is no longer a fluid responder. However, it is not profoundly explored how passive leg raising would affect healthy individuals living ordinary lifestyles and what would be the result of it. So we, understanding the basic physiological mechanisms that goes behind the passive leg raising and the true meaning of this test, formulated a hypothesis that probably healthy individuals should be non-fluid responders. So the aim of this pilot study was to evaluate the changes in the hemodynamics of those healthy individuals during passive leg raising test and to determine their fluid responsiveness. So this pilot study was conducted at our University Hospital Department of Intensive Care, and we examined 21 healthy individuals. Of course, the protocol for the trial was approved by our university's Biomedical Research Ethics Committee, and the main criteria for inclusion in the trial group was that the volunteers should be older than 18 years old, healthy at the present time with no history of chronic illness or any daily medication intake. And here is a simple scheme that helps me illustrate how the passive leg raising test is performed. So at first, the study subject is laying on the bed, and we tilt the head for about 45 degrees and let the study subject rest in this position, which is called baseline or semi-sitting position. We'll let him rest for 2 minutes, and afterwards, we passively raise the legs, and for the following 90 seconds, we collect the highest meanings of the hemodynamics data that we need. And the data was collected using a non-invasive impedance cardiography monitor, which is a more advanced monitor than the regular one and can give you more data on hemodynamics like cardiac output, stroke volume, cardiac index, and so on. So there were more female volunteers than males in our study, and the age median of the participants was 23 years, and the median of mean arterial blood pressure before the test was 93. I'm happy to share that we had some significant results. And here you can see heart rate changes during the PLR test. So we discovered a significant increase of the heart rate before and after the passive leg raising. So the medians being 78 beats per minute and 73 beats per minute accordingly. And also our analysis showed a significant increase of cardiac output median before the PLR test. Median being 6.8, and comparison after the test, median being 7.8 liters per minute. So what is this significant increase? By that I mean cardiac output being higher 10 or more %, and it was noted in 9 patients, meaning that 43% of the study participants actually were fluid responders. And in the rest 12 patients, we did not find those significant cardiac output changes, and that can probably show that they are non-fluid responders. So to conclude, overall, the PLR test that we performed on healthy individuals did cause a significant hemodynamics changes, and nearly half of the study participants showed a positive response to PLR, so opposing our hypothesis, and meaning that they should be considered as fluid responders. But overall, as the results are very half on half, they probably suggest that there could be both fluid responders and non-responders in the observed healthy population. And this probably can give us some new thoughts, maybe on a larger study, and how we should approach hypovolemia in the future. So thank you. And the biggest gratitude goes to our scientific supervisor, who helped us to design and conduct the study, and we actually felt like little scientists because we were able to do something real and not only to work with medical data.
Thank you very much for your presentation. One question. What could be the messages for clinical practitioners?
Thank you. So I believe the first message is that PLR, if done correctly, PLR is a very reliable tool for evaluating patients' fluid responsiveness, because we only mimic the fluid challenge and we do not infuse any fluids, and so we protect the patient and ourselves from the complications like fluid overload. And of course that, what else can be said? And maybe that, as I said, it can give us some new ideas on how we should approach a patient who's in hypovolemia, and do we really need to fill him up with fluids all the way if there are fluid responders in the healthy population as well? So I guess it just gives us some philosophical thinking to do and do a larger studies on that.
Thank you for your presentation. One question. You found that among healthy people, there may be fluid responders or non-responders.
Yes.
But did you do any evaluation of their fluid status before the conduct of the evaluation, like last meal or drink or something like that?
Yes, we actually did ask them about the fluid intake before the test, but as we tried to perform all the tests in the morning, we actually asked the volunteers that they could try to drink less as possible.
Thank
To be as hypovolemic as possible in the morning. Thank you.
Thank you for your presentation and discussion. And now I would like to invite Karolis Brasas to give us the presentation, the type of anesthesia and outcomes of mechanical thrombectomy in patients with acute ischemic stroke.
So, hello everyone. I'm one of the research of the study, and I'll present it to you. The study which I did together with my colleague Victoria Likite and the professor in the neurology department, Vaidas Patiešaitis. And our topic is the type of anesthesia and outcomes of mechanical thrombectomy in patients with acute ischemic stroke. So the main things I have to point out in our introduction is that ischemic stroke is the second most common cause of death after ischemic heart disease and the leading cause of long-term disability. Mechanical thrombectomy is one of the methods to reach brain reperfusion. There are two types of anesthesia that are used in mechanical thrombectomy. This is either conscious sedation or general anesthesia. However, the impact of the type of anesthesia used during mechanical thrombectomy on patient outcomes remains controversial. So the aim of the study is to evaluate the association between the type of anesthesia used during mechanical thrombectomy and hospital outcome of acute ischemic stroke treatment. So the methods we used that the acute stroke patients were treated in the Hospital of Lithuanian University of Health Sciences, Kaunas clinics, and undergoing mechanical thrombectomy were included. So as I said, patients were divided into two groups according to the type of anesthesia that was used to them. So it was either general anesthesia or conscious sedation. So our favorable hospital improvement was defined as decreased NIHSS score by 4 or greater points from the baseline. Favorable hospital outcome was considered using modified Rankin scale, which scored from 0 to 2, and discharge and favorable radiologic landmarks, successful reperfusion, so MTC from 2B to 3. So anything less than that, so for example, 0, 1, or 2A was considered as unsuccessful reperfusion. So all the analyses were performed using SPSS version 24.0. The difference of relationship was considered statistically significant when the significance of the applied criteria was anything less than 0.05. So our results that during that time from August 2021 till the March of this year, a total of 73 patients were included in the study. 40% of those received general anesthesia, and 33 people received conscious sedation. The probability of experiencing any stroke-related complications was significantly lower in conscious sedation group. As we can see, 75% versus 48.5%. And no significant difference was found in the rates of hospital improvement, so in the NIHSS score between the GA and CS groups. But there was a trend of the better hospital outcome in conscious sedation group, but not statistically significant. Rates of successful reperfusion, so MTC, was similar across two groups. The median door to groin time was 138.5 minutes in the general anesthesia group and 120 minutes in conscious sedation group. And the rates of NIHSS were similar in both general anesthesia and conscious sedation groups before mechanical thrombectomy and 7 days later. There was no significant difference found between the rates of hospital and NIHSS improvement when comparing both of those groups. So our conclusions is that our study showed that the patients who received the general anesthesia or conscious sedation during mechanical thrombectomy had similar hospital outcome and rates of successful reperfusion. The probability of experiencing any stroke-related complication was significantly lower, and a trend of better hospital improvement was observed in the conscious sedation group. And there further studies are needed to evaluate influence of anesthesia choice and to determine the prognostic factors of clinical outcome after mechanical thrombectomy. And that's it for us.
Thank you for a very interesting presentation. And I have two questions. Is it prospective study? Is the first one. And it is not clear about randomization. I mean, allocation of the patients into the groups.
So answering the first question, yes, that was the prospective study. So we collected all the data and while asking the patients if they want to participate in our study. So, and then what was the second question?
About randomization.
What you define by randomization?
I mean, how did you decide to which group you allocate the patient? So
yeah. So it was located by searching the anesthesia documents, and we found out that some of those patients were there was used general anesthesia, and some of those patients was conscious sedation. So by that we located them to either of those groups.
So actually, if there is no clear randomization, so it's your results are not convincing, because really you have to allocate patients to the group of general anesthesia or conscious sedation by computer generated or
yes, it was used using SPSS and all the data. I might not understand the question correctly, I think.
Hello, thank you for your presentation. As a neuroanesthesiologist, I looked at this work with very high interest, because you are investigating on the issue of worldwide ongoing discussions which anesthesia method is better for the patients. But you know, from the practical point of view, I can see a significant problem of patient selection bias, because when the anesthesiologist is considering which anesthesia method to choose, you look not only at the neurological examination of the patient, but also at all the vital functions and general condition of the patient, and the patients with acute neurological conditions are considered as with high risk of aspiration. So the level of our suspicion is very high, and when the patient is in a lower status of awareness, when they are less cooperative, then we are very likely to choose general anesthesia. And you know, this makes the bias that the patients which are in better awareness, in better neurological condition, will more likely go with conscious sedation, and the patients which are worse, despite being with similar NIHSS score, they will undergo general anesthesia. So this puts this significant problem, and I think that for the further works, you should include anesthesiologists to organize the study and to do it as correctly as possible.
Yes, I thought about that, and I mean, this work was done with the neurologist, and it was meant to be in the neuroscience department. So, yes, as I've heard from our professor and all of those people who work in neurology and how they choose it, the type of anesthesia. So it's mainly by stroke severity, I think. So low stroke severity patients who have NIHSS less than 8 points scored. So they go through conscious sedation, and anything more than that, so they'll get treated by general anesthesia. So that's viewing from the neurology point. So from anesthesia point, that definitely makes sense, and I think in the future, neurology department and anesthesiology department and intensive care department should work together and cooperate, like you said, to make a new study, which will be more accurate, I think.
Yeah, thank you. So I would encourage cooperation with anesthesia here.
We'll definitely do in the future.
Yeah, I agree with Marius, and just want to say that I suppose main problem of this study is that clinical states of patients could influence your results. Thank you.
What do you mean?
I mean that your findings, yes, could be influenced by patient's clinical state before intervention. Yeah. I mean that.
Yes.
Thank you very much.
So I don't think that it's because we only collected the data that after we evaluating the NIHSS score. So we collected all the data before that. So we haven't been evaluating that by ourselves. So yes, I think it's reasonable to do it in the future, and to check not only the score, but also the patient's general status, and as the former said, also the vital signs of it.
to give us the presentation of the effects of small dose ketamine on early post-anesthesia recovery after intraoperative remifentanil infusions in obese patients.
Good morning, everyone. Really honored to be here, and I hope you will enjoy our presentation. I am student Viltė Jotsaitytė, and today I would like to present you our research prepared together with fellow student Darija Safinova and scientific advisor Aurika Garabonskienė on topic effects of small dose ketamine on early post-anesthesia recovery after intraoperative remifentanil infusion in obese patients. So, as probably most of you know, safe and rapid recovery of patients after anesthesia is one of the most important factors for good operating room turnover. Intraoperative low-dose ketamine is an attractive adjuvant to traditional pain management protocols, enabling to reduce opioid consumption and their side effects. However, the rate of recovery of patients after anesthesia must also be taken into account when developing methods of anesthesia and postoperative analgesia. The aim of the study was to assess the significance of low-dose ketamine for early post-anesthesia recovery of obese patients by comparing post-operative recovery time, including spontaneous respiration recovery time, time of extubation and eye opening, recovery of orientation, and beginning to respond to verbal command, and also vital signs such as arterial blood pressure, heart rate, and saturation. In December 2021, January 2022, we gathered a prospective randomized double-blind placebo-controlled study. The study included 53 bariatric patients in the Hospital of Lithuanian University of Health Sciences undergoing laparoscopic gastric bypass surgery with remifentanil-based anesthesia. All of the patients were divided into two groups. So the first group was a test group of 23 patients, and all of them received 0.3 milligrams per kilo for lean body mass of ketamine during anesthesia induction. And the second group was test group of 30 patients, and they received the same amount of saline during anesthesia induction. Vital signs and recovery time were evaluated post-operatively every 2 minutes after termination of remifentanil infusion. As seen in these tables, test and control groups were both similar in terms of demographic data, body mass index, and total use of remifentanil. When assessing patients' post-anesthetic recovery, we also didn't notice any differences between control and test group in spontaneous respiration recovery time, time of extubation, eye opening, beginning to respond to verbal commands, and recovery of orientation. Data only differed when comparing vital signs. So as seen here, the test group and control groups were similar in terms of heart rate and saturation, but differences can be seen in arterial blood pressure. So in systolic blood pressure median in test group was 118, and in control group it was 131, and diastolic blood pressure median was 64 in test group and 76 in control group. As a result of this study, we can determine that a low-dose ketamine during anesthesia induction was not relevant for early recovery of obese patients after anesthesia. Values of vital signs were within normal limits in both groups, but slightly lower blood pressure was observed in the test group. And based on this data, it can be concluded that small-dose ketamine during induction of anesthesia does not adversely affect patients' postoperative recovery and does not have any impact on operating room turnover. These are our references. Thank you for your attention. And now I will try to answer your questions.
Thank you for the interesting study. And one question about sample size of a study. How you calculate the sample size of the study?
Sorry?
Sample size.
Yeah.
How you calculate?
How did we calculate the sample size?
Yes.
This is actually a follow-up study from previous managed study on post-operative pain management. So we gathered the same amount of patients in all of the groups, like in the previous study.
But you don't use standard deviation of your study or do some pilot measurements. You do not do that.
We calculated standard deviation. Maybe it's not shown here, but we did calculate it.
Okay, thank you.
Thank you very much for your presentation. It was very interesting to listen. But you know, your study design is very good, actually. The best of these all presentations, but the results, I think that you had to include early postoperative period pain, because you know remifentanil causes sometimes hyperalgesia, and a little dose of ketamine can cope with this. And actually, when patient is awakening, maybe you could get better results on postoperative pain, because in your study you have results that the blood pressure in ketamine group was less systolic on awakening. It can mean that for these patients it's less pain, so it's less hemodynamic reaction. I think that the main target of this study has to be postoperative pain quality. I mean, in early postoperative period, but not patient awakening, because actually if you are using doses of 0.3 milligrams per kilo, it means it's very small dose. And if you are giving in the induction of anesthesia, it is, you can predict that after the surgery, which lasts about 2 hours or maybe more, it can be almost disappeared, this effect, but it can be a very good effect on postoperative pain after remifentanil anesthesia.
We actually did do the study, and it can be seen on the conference poster site on the internet.
So it is only part of your study?
Yes, yes. Thank you.
I would like to thank all of the presenters for their delightful presentations. Now let's take a 7-minute break while all the scores are counted. Right after the break, we will announce the winner of the session. Welcome back. I would like to thank the jury for their work today. Applause, please. So, after counting all of the jury points, I'm delighted to announce that the winner is Viltė Jocaitytė. Congratulations. So, the anesthesiology and intensive therapy session has finished. I would like to thank all the participants for attending the 6th International Health Sciences Conference. Hopefully, it was interesting. And now, I invite you to join the rest of the conference and come to listen to the keynote speaker today, Associate Professor Dr. Vincas Urbonas. Thank you all for your interest in science. Have a nice day.
Okay, so welcome everyone to the 6th International Health Sciences Conference Public Health Session. My name is Augusta, and I will be leading this session today for you. So first of all, on the behalf of the Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank our patrons. So firstly, Fresenius Kabe, Roche, Medita, Origmed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. And we also hope that IHSC will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientists all over the world. Additionally, I would like to express gratitude for all of the reviewers and today's jury. So please welcome Professor Rūta Ustinavičienė, Professor Janina Petkevičienė, Professor Richardas Radišauskas, Professor Apolinaras Zaborskis, and last but not least, Rita Raškevičienė. We kindly ask jury members to remain at the session until the points are counted and the winner is announced. Before starting the session, I would like to remind you of some rules. So today we will hear 9 presentations, and all of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the section, and the winner will get great sponsored awards. That will include gifts from Bioderma, Sapiens, Chrysostomus Bookstore, Origmed, Gintarinė Vaistinė, Fielman, and Medita. Winners will receive their gifts after the session. And moreover, presentation should last no more than 7 minutes, and there will also be 3 minutes dedicated for questions from the jury members and listeners. So please note that, and if your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in the given time frame as well. And moreover, each presenter will receive a certificate that will be sent to their emails after the conference, so please look out for that. And if you have any questions, it would be great if you express them right now. Okay, so best of luck to all the presenting authors. And I would like to invite the first presenter, which will be Gabriela Bartkutė, with her topic, Attitudes of Healthcare Professionals Towards COVID-19 Vaccine.
Hello everyone, my name is Gabriela Bartkutė, and today I will present our research about attitudes of healthcare professionals towards COVID-19 vaccine. And firstly, I would like to thank our scientific supervisor, Jolanta Sauserienė, for her time and help. So, to begin with, COVID-19 caused a global pandemic in 2019, and 2 years later, it remains a leading cause of death. It is believed that vaccination provides strong protection against severe illness, complications, and may reduce virus transmission. The attitude of healthcare workers on the COVID-19 vaccine may affect the public perception of vaccination and even management of the pandemic. Surveys that were conducted abroad suggest that many healthcare professionals have a positive attitude towards COVID-19 vaccination. So the aim of our study was to evaluate the attitude towards COVID-19 vaccination of Lithuanian healthcare professionals. In order to determine the attitudes of healthcare professionals working not only in Kaunas, we decided to conduct an anonymous online survey. It was carried out from August to December of 2021 in Lithuania. The study included 860 healthcare workers, such as physicians, resident physicians, and nurses. Statistical calculations were performed and chi-square test was used. Statistical significant findings were assumed with p-value below 0.05. So results. Over 88% of our respondents were female and about 12% were male. More than half of the subjects were under 39 years old, and the graphical presentation of age distribution is shown on your right. Speaking about current location of respondents, the majority of them were located in Vilnius and Kaunas. The remaining 30% were located in smaller towns and cities of Lithuania. And among healthcare specialists, 43% were nurses, 37% were physicians, and 20% were resident physicians. Moving on to COVID-19 vaccination status, over 90% of our responders were already vaccinated, and about 74% would consider revaccination if needed. By comparing physicians, resident physicians, and nurses, physicians statistically significantly were more likely to get vaccinated compared to the nurses and resident physicians. About 87% of healthcare professionals received community vaccine, and both groups, vaccinated and unvaccinated healthcare professionals, stated that they are satisfied with their decision. So the main reason to get vaccinated was a desire to protect themselves. The second one was a desire to protect others, then recommendations from the government and pressure in the workplace. Reasons not to get vaccinated was possible side effects of the vaccine, doubts about the effectiveness of the vaccine, immunity after COVID-19 infection, and medical contraindications. Moving on to attitude about COVID-19 vaccine safety and efficacy, according to our respondents, the safest and the most effective vaccines were Comirnaty and Moderna. Only minority of the healthcare workers believes that COVID-19 vaccines are unsafe and inefficient. Speaking about recommendations for relatives and patients, respondents that do not consider vaccination in the future statistically significantly less often recommend vaccination for their relatives and patients in comparison with vaccinated healthcare professionals. And finally, speaking about the knowledge, about 68% stated that they have sufficient knowledge about COVID-19 vaccination. About 30% would like to have more information, and the remaining 2% stated that this topic is not relevant to them. And by comparing vaccinated and unvaccinated respondents, the majority of unvaccinated respondents stated that they actually need more information. So, all things considered, over 90% of healthcare professionals were vaccinated, and only three-fourths would consider revaccination. Physicians were more likely to get vaccinated compared to the other groups, and the main reasons to get vaccinated included a desire to protect themselves and others, recommendations from the government, and pressure in the workplace. While the main reasons for refusing vaccination were side effects and doubts about the effectiveness of the vaccine, and of course, acquired immunity after COVID-19 infection. And the majority of unvaccinated healthcare professionals stated that they are lacking knowledge about COVID-19 vaccination, and this group significantly less often recommend vaccination for their relatives and patients. This is our references, and thank you for your attention. Do you have any questions? Yes, please.
Thank you. What is your strengths and limitations of this study?
Yes, we do have them. So, as our survey was conducted online and published on social media, we could not have the data from elderly physicians, nurses. We could not reach them. So, we would like to do another survey, not online.
And can you extrapolate your results for whole Lithuania?
Well, we think that, as I said, attitude towards COVID-19 vaccination is positive in Lithuanian healthcare workers.
Thank you for the nice presentation. I enjoyed it very much, and I would like to ask you about your contribution to the study. What you did on yourself?
Oh, we did everything basically. We conducted the survey.
We were the authors of the questions, of them 16 questions, and as I said, we published it online and proceed the data.
I have some remarks. We talked about the differences, the majority more or less, and I see only one P in your presentation. So this is not for the ordinary public, this is research presentation, so you have to show more statistical data in your presentation.
We actually had few of them. I don't know. I could show you.
Not in all slides, not in all
Yeah.
pictures, not in all.
I understand, yeah. So thank you.
Thank you so much for your presentation, Gabriela. Before moving forward, I would like to ask the jury to use the microphone when asking questions so people could hear you clearer. And next up, we'll have Indra Strasnitskaite presenting the analysis of sensitizing components of hair dye products available on the Lithuanian market.
Good afternoon. My name is Indra Strasnitskaite. I'm from Vilnius University, and today I will present mine and my colleagues Austėja Samuolytė and Professors Laura Malinauskienės work called Analysis of Sensitizing Components of Hair Dye Products Available on the Lithuanian Market. In general, the prevalence of occupational contact dermatitis is up to 10.6%, with contact dermatitis, both allergic and irritant, accounting for about 80% of all causes of occupational skin disease. However, hairdressers tend to be one of the most often affected groups because of their intense contact with various chemicals, much of which have sensitizing properties and are categorized as strong sensitizers by the European Commission. Sensitizing ingredients in hair dyes is an interesting study topic as it raises awareness about a higher incidence of allergic and dermatological diseases among the general consumers and hairdressing professionals. The aim of the study was to determine the most common hair dye allergens in the Lithuanian market and the average allergen number in different price intervals according to marketing slogans and the type of store that they were sold at. The data was collected in March of 2019 by photographing the labels of the products. Products were selected from 8 different stores. 2 stores were general beauty stores with 75 products found in them, 2 stores that were marketed towards professionals with 6 products found, 2 stores were specializing in ecological and natural products, and the last 2 were pharmacies with 5 products found in them. Data was evaluated in accordance with the allergens that are described in the hairdressing series that is made by the company Chemotechnik in Sweden, and the average number of allergens was determined according to the sales location, the price interval, and the advertising slogan. The data was calculated using Microsoft Excel. The 10 most common ingredients are presented in this graph. The percentage was calculated based on all sensitizing ingredients found. The most commonly found was M-aminophenol, toluene 2.5-diamine sulfate, resorcinol, and panthenol, and all of them accounted for more than 10% of total ingredients found. P-aminophenol, cocamidopropyl betaine, and 2-methylresorcinol were detected in a similar frequency, around 9%. I'll shorten the name to MI plus MCI. PPD and sodium metabisulfate and other ingredients were found less frequently, and they all accounted for up to like 5 to 7% of total sensitizing ingredients found. Average number of allergens in a product according to the sales location were 2.7 allergens on average were found in general stores, 5.4 were found in pharmacies, 3.8 were found in professional stores, and 1.6 was found in eco stores. The average number of allergens in a product, according to the slogan, was like this. 3.6 were found under the slogan of professional. The natural slogan had 2.9 allergens on average, and the products with no slogan had 2.5 allergens on average. The average number of allergens in a product, according to the price, were 2.6 in the lowest price range, up to 5 euros, 2.9 from 5 to 10 euros, and 3.9, the most expensive price range, more than 10 euros. So the conclusions would be that around 80% of all the hair dye products that we reviewed in our market survey contain sensitizing ingredients. And products with the highest average number of allergens were sold in the pharmacy and were priced at more than 10 euros. Products labeled as professional had the highest average allergen number. So those are my references, and thank you very much for your attention. If you would have any further questions.
Pharmacy stores, they have products with the highest amount of allergens. And also, according to price, there is lower price, lower amount of allergens. So really just it's interesting. But so do you see?
What was I expecting? Yeah. Yeah. Well, just as you said, I expected a completely different outcome of this. However, what was kind of surprising to me was that, as you've probably seen, the products were kind of really unequal. Mostly products were sold in general beauty stores. Pharmacies had way less products in the physical stores, which is what we decided to stick with, just like a market, what a consumer would see walking into a store, what type of products. However, online, if you check, they have way more products. And what surprised me was that pharmacies had very similar products to general beauty stores online. However, stores for professionals or eco stores had different products. So that was kind of surprising because you would expect pharmacies to have maybe more, I don't know, some kind of different production than you would find somewhere else.
Thank you for your presentation. I would like to ask about which product are very bad for health, for human health, from your 10, maybe from Tolen and others, and which product, comparing this very bad product, distributed in some stores and in some products of hair dye.
So the ones that are considered the strongest sensitizers were toluene 2.5 diamine sulfate, M-aminophenol, P-aminophenol, and if I remember correctly, the PPD. The top two were, as you can see, were the strongest sensitizers. PPD was surprising because it is in general one of the most often found allergens in hair dyes overall over Europe, in Asia, in the US. However, here in our survey, it was one of the least frequently found, so that was surprising to us as well. But yeah, the top two are the strongest sensitizers, that according to the European Commission.
Thank you.
It is difference between dyes which are devoted to so-named blonde hair or to dark hair.
So when we collected a photograph, we took a specific, I don't know, like type of hair dye, let's say L'Oreal something, and then we took for dark hair, for brown, for red, and for blonde to see if there's a difference. They're only like the dye part. These the ingredients here mostly are used either for, I don't know, as preservatives, either as to bind the dye to the hair. They're not dyes themselves, most of them. So the difference was just the difference is in the dyes, not in the products here between the different colors.
Yeah, because for blondes there are special materials which
Mhm.
remove color and glitter.
Yeah. So I understand that. Is that all? Yeah. Or yeah.
How do you select those locations and how do you select the places where you collected this data? How do you select it? What the principle was to select this?
So we wanted, as I've mentioned, we wanted to see different types of stores, if there would be a difference between them. And then we just chose the biggest supermarkets where we hoped to find the most of those stores, let's say. And then we just also had to ask the administration of each store so they would allow us. And then when we found 2 of each, then we were able to photograph them. But we just wanted different samples of different types of stores. And then we chose the biggest supermarkets that had them.
But in big supermarket, there are, let's say Acropolis, there are some, like say Maxima and other stores that specifically sells only this cosmetics. So, or you select the, what principle was to select such location?
So, yeah.
Or some specialized stories or general stories like Maxima, where only small
No,
sales
we tried for the general ones were the ones marketed towards beauty. Then there were marketed towards professional. Like the principle was just to, I don't know, just to find different stores of each type of I don't know, market. Like the ones that were marketed towards professionals, let's say, they were also in the supermarkets, but they had specific hair dyes, if I understand your question correctly.
Do you think that the number of those allergens can be related to the number of the products sold in one or other places?
Of course, and I think that this is one of the biggest limitations of the study is that more products are needed to represent, for example, ecological stores or so, but then in general, ecological stores sell less hair dyes than you would expect to find in beauty stores, for example. So it's also hard to compare those when there's a difference in general in the product.
Yes,
amount.
I would like to say that it's difficult to compare because there's a different number of such products.
Yes, that is true.
I suppose that the principle for choose these examples is not shops, but companies which produce these products.
Not exactly, because as I've mentioned, the companies that are sold in general beauty stores were similar to the ones that, for example, you can find in the pharmacy. So the ones that were different were for the professionals and the ecological ones, which mostly contained henna dyes, for example, and things like that. So it's not exactly based on the company, let's say, that produces, as more of the like what they're marketed towards. I'm getting a lot of questions.
This is because your presentation is really very interesting and very important, I think. Do you plan to publish your results and to inform public, maybe for media?
Yeah, there was a plan, but we also wanted to compare it according to another research done in Santaros clinics that was done, a skin patch test done to hairdressers and people who dye their hair, and then to compare if the ones that we found that were the most commonly found allergens were the same ones that were the most commonly sensitized by the people. If I formed the sentence correctly, I don't know if you understand. So we wanted to compare that and then, yeah, maybe publish the results. Is that it? Yeah. Okay, thank you.
Thank you so much for your presentation, Indra. And next up, we will hear from Jūratė Koreivaitė with her topic, emotional state and job satisfaction in hospital staff.
Okay, hello everyone. I would like to present you my research about emotional state and job satisfaction among hospital staff. And firstly, COVID-19 had a lot of impact on everyone, especially on medical workers and hospital staff. It is known that medical staff experience medium levels of stress during the pandemics, and it's really important for them to use adaptive emotion regulation strategies to cope with it. Research shows that non-adaptive emotion regulation strategies, such as expressive suppression, may be a risk factor for burnout, while adaptive emotion regulation strategies, such as cognitive reappraisal, may reduce that risk. And when we are talking about job satisfaction, it is known that medical staff usually are satisfied with their job, although they are not very happy with their pay and reward. So the aim of my study was to evaluate hospital workers' job satisfaction, perceived stress, used methods of emotion regulation, and to assess the relationship between all of those phenomena. A study was conducted in summer at Šakiai Hospital in Lithuania, and 121 staff members were included in the analysis, although 125 agreed to participate, but we had to eliminate their surveys because of incompletion. And as you can see, most of the respondents were females, which age mean at about 50 years, living with their husbands or wives, and having work experience of more than 15 years. It's really interesting that most of the respondents chose not to specify their job position. And for the survey, I used 3 scales, each for one of the phenomena. And first of them was perceived stress scale, which was out of 10 questions, and people were supposed to choose their answers out of 5-point Likert scale, and it measured 3 levels of stress, low, medium, and high. For emotion regulation, I used Grosses and Joan emotion regulation questionnaire, also out of 10 questions, except that it was 7-point Likert scale, and it showed how often is used and at what intensity, cognitive reappraisal, which I mentioned before, and expressive suppression. And for job satisfaction, I used Spector's job satisfaction survey. It's originally conducted out of 9 subscales, but I only used 4 of them. It was pay, supervision, operating conditions, and coworkers. And the answers was showed in 6-point Likert scale, and it measured 3 satisfaction levels. So the employees were either satisfied or unsatisfied or ambivalent. And statistical analysis was made using Excel and SPSS. For mean comparison, I used ANOVA, and for correlations, Pearson and Spearman. Now the result part. So as you can see, most of the hospital staff were really satisfied with their coworkers and supervision, although they were not satisfied with pay, and ambivalent with operating conditions. And as you can see, mean distribution supports my previous statement. If we look into distribution by job position, we can see that management staff were mostly more satisfied than all others, except for operating conditions, and medical staff, which includes medical doctors, nurses, and junior medical staff, were least satisfied. Medical workers, all hospital staff experienced medium levels of stress and used cognitive reappraisal and expressive suppression equally at medium intensities. We did find associations between perceived stress and job satisfaction, mostly medium and negative, except for operating conditions, which we did not find. Associations between emotion regulation and job satisfaction was not found, statistically significant at least. And associations between emotion regulation and perceived stress, well, that one's interesting because we did find weak but statistically significant correlation among cognitive reappraisal strategy and perceived stress, but we did not find association between expressive suppression and perceived stress. So to conclude, I can say that most of the respondents were satisfied with their coworkers and supervisors, but they were not happy with their pay and ambivalent with required rules and procedures, which are operating conditions. Hospital workers reported experiencing medium levels of stress. Emotion regulation strategies, both adaptive and non-adaptive, were used equally and at medium intensity, and weak to medium correlations were found between job satisfaction and perceived stress, as well as cognitive reappraisal and perceived stress, although no significant correlations were found between emotion regulation and job satisfaction, and expressive suppression and perceived stress. These are the references that I used during the research, and thank you.
Thank you for your presentation. What is your imagination about that 36.4% of your interviewed staff do not mark their position? Why?
Yeah, that was really sad, to be honest. I think that maybe it's because small town, small hospital, they were not sure if they will really remain anonymous. I was trying to assure them. We all were. I mean, we collaborated with psychologists of the hospital, and we assured them that it will be anonymous, nobody will know you. We did not distribute any departments of the hospital, only the job position. But I think that trust is what they lacked, because I'm new and they didn't know me that well.
It was online survey or paper-based?
It was paper-based survey.
Thank you. You have argued that several percent of staff, for example, most of staffs, 74% was satisfied with something. What were criteria for definition for classify these participants into groups? What were criteria? What criteria you used?
Into groups of satisfaction, like different. Well, Spectre scale has 9 different subscales based on questions. There's a lot of questions there. We used 4 of them, and 4 of them each had 4 questions. And based on that, we knew which respondents were satisfied with which.
Did you find this criteria in literature, or you created this criteria?
It was in literature. It was based on the scale that Spectre created.
What do you think? So different professions, starting from the technicians to medical doctors, only few medical doctors, if I understand, tell us that they are really medical doctors, can influence the results of your study. This very broad profession.
Yeah, I think it was really important that we try to take a look at the broader sense, because all of the literature was based on medical doctors.
I'm sorry, but we have run out of time for questions, so you should wrap up.
Yeah, okay. All of the research, well, not all of it, but a lot of research is made about medical doctors or medical staff, a lot of about nurses, but not much about all the hospital. And it affects, I mean, everything that happens in a hospital affects all of the workers. So I think it was really important to know, and the results we found, well, just because they did not specify their job position might be a challenge, but it was really important that we know all of them, not only some of them. Okay, so thank you.
Thank you so much for your presentation and also the questions from the jury. Next up, we will hear the presentation of Karina Statkevičienė, and her presentation will be about medical students' knowledge of post-exposure prophylaxis for blood-borne viral infections.
Karina Statkevičienė. I'm a medical student at Lithuanian University of Health Sciences, and today I'm going to talk about the medical students' knowledge of post-exposure prophylaxis for blood-borne viral infections. The risks associated with blood-borne pathogens, especially human immunodeficiency virus, hepatitis B virus, and hepatitis C virus in healthcare workers and students are often ignored, and insufficient attention is paid to post-exposure prophylaxis. And it is important to know that a human immunodeficiency virus, PEP, can be initiated within 72 hours after exposure, while hepatitis B virus PEP is effective if administered within 7 days and ideally within 24 hours. The use of post-exposure antiviral therapy against hepatitis C virus remains controversial, and it is not used in Lithuania. So our study aim was to assess and compare medical students' knowledge and self-assessment of PEP for blood-borne viral infections between countries. And the study was conducted using an anonymous survey, and clinical medicine, as we know, starts from the third year. So we decided to choose from third to 5-year students, and 6-year students were not included due to low participation, and data analysis was performed using SPSS statistics. So in study participated 162 students, and 3 groups was almost equal, and about 93% of the students had heard of hepatitis B virus PEP, and only about 38% correctly identified both PEP methods, revaccination and immunoglobulin. And the 5th-year students responded better, while the 3rd-year students answered the worst. About 75% of students mistakenly believed that hepatitis B virus PEP becomes delayed and ineffective after 24 hours post-exposure. And slightly better students' knowledge was observed for human immunodeficiency virus PEP. About 41% of students reported that its effectiveness could be expected if antiretroviral drugs were administered within 72 hours of the incident. However, about 19% of respondents had never heard of human immunodeficiency virus PEP. About 52% of students incorrectly answered that hepatitis C virus PEP is also available in Lithuania, and third-year students were the least likely to be wrong. Fifth-year students rated their knowledge of PEP most critically, and overall, most students rated their knowledge as good as very good, and more than 30 of third and fifth-year students said that they received enough information about PEP during the study years, and unfortunately, much was forgotten, while about 44% of third-year students said they received insufficient or no information at all. So the results showed that during the study year, medical students are indeed introduced to PEP. However, both the students' response and the subject's assessment of their knowledge showed that knowledge about PEP is insufficient to start medical practice safely, and the knowledge of the students did not differ much depending on the course in which they were studying. So that's all. Thank you for your attention.
Thank you for interesting presentation. I can comment that really a low level of more knowledge is devoted to safety of medical staff, and in which subject students are waiting to hear about this problem, and from where they are gaining this knowledge.
I think this is the problem of this is that we have a lot of information what to choose in these situations, but we don't have enough information what is the time then we can use this post-exposure prophylaxis. And usually information is given
in what subject you received such information? In what subject?
In immunology and also in other cycles like gastroenterology.
Could you tell, how did you select your respondents? Was this sample those who need to participate?
We decided to select students from third to sixth year, but sixth year students don't responded good, and we don't include them. And we selected exactly that year students because this year's clinical medicine, not preclinical medicine.
But how did you select it? I'm asking how. What must
we selected data with a questionnaire by university email.
Do you think that those respondents represent whole population, whole students from third to fifth year? It's representative sample or not? How do you think?
I guess it is representative, but maybe not enough student is included. I guess it will be better if all students participate.
Did you calculate its sample size for such study? What sample size are needed for such type of study?
No, we don't calculate.
So the time for questions is up. So thank you, Karina, for your presentation. And next up, our next presenter will be Aista Gulevičiūtė, who will present on the topic of awareness and attitude of women in Kelmės city towards primary and secondary cervical cancer prevention.
So hello everyone, my name is Aista Golubičiūtė and I want to introduce my study about awareness and attitude of women in the Kelmė city towards primary and secondary cervical cancer prevention. So cervical cancer is one of the most common cancers in Lithuania, and to reduce it, primary and secondary prevention programs are being used. It includes vaccination against human papillomavirus and participating in cervical cancer screening program. However, more than 5,000 women are still receiving abnormal cervical screening test results every year, and for more than 500 of them, these changes develop into cervical cancer. And after analyzing causes of the situation, it was found that there is a problem in lack of knowledge about cervical cancer prevention. Women simply don't know what causes cervical cancer and how it can be prevented. And what is more interesting, women's awareness of cervical cancer prevention is particularly low in rural areas of the country. That's why we chose to do a study in a smaller city. Our study aim was to assess the awareness and attitude of women in the city of Kelmė about the primary and secondary prevention of CC. So anonymous questionnaire survey was conducted in February 2019 in Kelmė city. 203 women were interviewed and hypotheses about dependence between different variables were verified by calculating the T-square and Z criteria. The differences between the variables were considered statistically significant when P was less than 0.05. So let me introduce the results. So first of all, we asked our respondents what is the main risk factor for CC, and 68% of respondents correctly identified HPV as the main risk factor for CC. However, 11.3% of people said that HPV is not the main risk factor for CC, and 20.7% said they do not know what is the main risk factor for CC. And what is more interesting that we have we found dependence between respondents' knowledge and education. So as we can see, these people who didn't know about the main risk factor, they had lower than post-secondary education. So this difference was statistically significant. Then we asked people about awareness of free HPV vaccination of 11 years old girls, if they know that we can vaccinate girls for free, and only 30% of people said that yes, they do know this fact, and even 70% of people haven't ever heard about this fact. And what's more interesting, we found that this knowledge depended on age, occupation, and education. So people who were younger, employed, and with higher education, they were aware of this fact compared to older, unemployed, and unemployed people with lower education. Here you can see a respondent's attitude towards adequacy of information on HPV vaccine depending on age and education. We asked the main question, how do you think if there is enough of information about prevention and about HPV vaccination? So only 10.3% of women said that yeah, there is enough, while 84.2% of women said that it is not enough of information. So please remember this number because this is the key of our study. And 5.4% of people said that they simply do not know. And this depended on age and on education. So as we can see, younger people with higher education were statistically significantly more likely to see that there's enough of information compared to older women with lower than higher education. This table shows participation of respondents in selective CC screening program, and as we can see, only 65% of respondents participated at least once in this program, while 35% of people said they haven't ever participated in this program. And again, we found a relation between this participation and age, occupation, education, and marital status. So as you can see, older people in the age group of 51-60 unemployed with lower than post-secondary education and unmarried, they haven't participated in this program at least once. Here you can see results of our last questions, and we gave the question how our respondents think if it's possible and if it's a good idea to make HPV vaccination free and compulsory for all women and for all ages. So 61.6% said that, yeah, it should be compulsory and free for all women. And we found dependence of this attitude and education. So as we can see in the picture, people with lower than post-secondary education were statistically significantly less likely to agree that this vaccination should be compulsory and free for everyone. The last table shows respondents' attitude towards the idea that participation in selective CC screening program should be compulsory. So we can see that 71.4% of women said that, yeah, it should be compulsory to participate in this program, while 28.6% said they do not know. And again, we found a dependence between this attitude and education and marital status. So women who said that women who had post-secondary education and were married or lived with a partner said that they were more likely to agree that participation in this program should be compulsory for everyone. So to conclude everything, Kelme women lack of information and education on the importance of HPV vaccination and CC screening. Attitude of primary and secondary prevention on cervical cancer varied and was statistically significantly dependent on age, education, and marital status. And it is important to increase an availability of information on HPV vaccines and importance of this primary CC prevention program, especially for women that are older and with lower education. So here are my references. Thank you for your attention. Are there any questions?
What is your opinion? It is really important, let's say for 50 years old women, to be vaccinated against cancer?
Well, I think that it's not exactly important to be vaccinated, but to have knowledge that there is a vaccination. Maybe they can share this knowledge with their daughters, and then the vaccination importance became more important, because when you're younger, you can, and when you are vaccinated against HPV, that means that the risk of having CC is lower than in the old age. So I think that it maybe the key is not about vaccination, but about knowledge of vaccination, and that there is a prevention.
If I understood you ask about the opinion, it is yet it must be compulsory and for all age groups.
Yeah.
So I don't think that this question was really very good.
But, well, I also found studies which shows that even if you're older and you're vaccinated, there is still a small benefit of it, because the risk decreases, even though you're in the 50 years old or older. Anyway, risk decreases with vaccination. So I think, in my opinion, it is important.
A very interesting study. And my question is just a little bit maybe wider. How to reach this women who are in low socio-economical status, living in countryside, how to reach them to inform about vaccination?
Yeah, this is a very good point, because I think there's probably work of public health workers, because I think they should, I don't know, maybe go to smaller cities, maybe they do some presentations in schools, and I mean, I'm talking about smaller cities, and they should educate more and more. I'm not sure how it can be made, but I think that there's a huge problem, and health workers should pay attention to this and think better how to increase information and information about this problem.
Thank you for your questions. We have run out of time again, so let's wrap up the presentation. Thank you. So next up, we will be hearing from Justina Valenčiūtė, and her presentation will be about different attitudes of patients with multiple sclerosis towards COVID-19 vaccination.
Hello everyone, so today I'm going to present the work that I and my colleague Dovilė did. It is called Different Attitudes of Patients with Multiple Sclerosis Towards COVID-19 Vaccination. So during the COVID-19 pandemic, vaccination became an important tool to prevent a severe illness, and it is proven that COVID-19 vaccines are safe and effective for people with multiple sclerosis, for short MS. And however, coronavirus outbreak has raised awarenesses of vaccine skepticism. In UK and other countries, some studies evaluated the link between willingness to get vaccinated against COVID-19 and social demographic factors or MS exacerbation. And in Lithuania, specific reasons for vaccine hesitancy among people with MS have not been described. So we decided to create a survey from the 1st of November 2021 to the 1st of February 2022 to estimate positive and negative attitudes of COVID-19 vaccination among patients with MS. So our aim was to evaluate the peculiarities of vaccination against COVID-19 infection in patients with MS and their attitude towards vaccination. The study was approved by Bioethics Center of Lithuanian University of Health Sciences, and the research was performed at Kaunas Clinics Neurology and Diseases of Nervous System Outpatient Unit. And 100 people with MS were asked to fill an original questionnaire, and in total 80 patients responded. And the survey was about social demographic aspects such as age, gender, employment status, education level, also if they had MS exacerbation, if they had COVID-19 vaccine, and also their attitudes towards this process. And data was analyzed, and we used calculation of the chi-square and Mann-Whitney U test, and p-value, which was statistically significant, it was below 0.05 for each hypothesis. So our results, as you can see, that among 80 respondents, more than half were female. And in another chart, you can see that 82.5% of respondents were vaccinated, and only 17 of them were not. And there are also another two charts with positive and negative attitudes toward COVID-19 vaccination, and most popular positive opinions were that COVID vaccines have more benefits than harm, also willingness to get an immunity, and there is enough evidence-based information. And mostly agree negative view, which was more than half, that was fear of the side effects. Also, the vaccine was developed too fast. And only 15% of the patients said that it was doctor's recommendation not to get COVID-19 vaccination. And also, it is important that intended uptake was strongly associated with younger age and high education level and employment status, which meant that most of the respondents had jobs. And there was no further link between other social demographic factors such as gender, residency, and even with exacerbation of MS. And our conclusion is that even though there are some hesitancy about COVID-19 vaccination, people with MS were more likely to take COVID-19 vaccine because of their positive attitude towards this process. And again, that willingness to vaccinate was associated with respondents' age, education level, and employment status. And here are references, and thank you for the attention.
I have two questions. One, why you decided to choose such disease, multiple sclerosis?
because we thought that this disease is kind of immunosuppressive and the patients taking immunosuppressive treatment, and maybe we thought that it would affect vaccination, but we got really different results than we expected. So it was interesting to see.
Used very interesting statistical methods or statistical test, Q square. What calculate this test? What test?
V square and G square. Oh, sorry.
So it was mistake in everywhere in this and in the abstract and also.
Do you evaluate view to vaccine or attitude to vaccine according stage of disease?
No, we couldn't because biotech centers didn't give us permission to do that, to look at the patient's history charts to see what they have, a clinical stage of the patient, so no. That's it. Thank you.
Thank you so much for your presentation. And now moving forward, our next presenter is Anastasia Kayandere, and their topic is burnout, depression, and anxiety among healthcare workers.
Hello, everyone. I hope you hear me well. My name is Anastasia Kayandere. I'm a fourth-year resident in psychotherapy, and I'm a student of a Latvian university. And today I'm going to present my study, Burnout, Depression, and Anxiety among Healthcare Workers. My scientific supervisor is Dr. Roland Ivanov. So, burnout is defined as a syndrome that consists of emotional exhaustion, cynicism, and reduced personal efficacy at work. And the COVID-19 pandemic, as we know, has affected the working conditions of healthcare workers. For example, during the COVID-19 emergency state in spring of 2021 in Latvia, the study was conducted, and about 1 in 4 physicians in Latvia has had depressive symptoms. Healthcare workers in general are at high risk for burnout. For example, according to Medscape 2020 report, about 42% of physicians reported that they are burned out. And according to one study of US physicians, like 54.4% of them reported that they had had at least one symptom of burnout. Up to now in Latvia, there has been little research done on burnout. For example, last time it was studied among physicians in 2015 and among nurses in 2021. Why depression and anxiety? Because depression and anxiety have burnout-like manifestations, and they can be considered as diagnoses associated with burnout syndrome. So the aim of the study was to study the prevalence of burnout symptoms, clinically significant depressive and anxiety symptoms among healthcare workers at National Rehabilitation Center Vaivodi, and also to evaluate the correlation of burnout syndrome, depression, and anxiety at the population. This cross-sectional study was performed in January 2022. During 1 month period, healthcare workers in person completed the socio-demographic questionnaire, burnout syndrome questionnaire, which was Mustache Burnout Survey General Survey, the patient health questionnaire, which is a screening tool for depression assessment, like assessment if there is a clinically significant depression and its severity as well. And the generalized anxiety disorder, yes, which is a screening tool for generalized anxiety disorder. Mustache Burnout Survey consists of 3 subscales, which were analyzed separately. There are emotional exhaustion subscale, cynicism subscale, and professional efficacy scale. Exhaustion measures feelings of being overextended and exhausted at work. cynicism measures an indifference or distant attitude to one's work, and professional efficacy scale measures satisfaction with past and present accomplishments at work, and also like individuals' expectations of further accomplishments. Statistical analysis was performed by IBM's SPSS Statistics. 98 people participated in the study, 13 men and 85 women. As you can see, the high emotional exhaustion level was reported by 27.6% of participants and average by 27.6% as well. High cynicism was in 22% of participants. And actually, the professional efficacy level data are quite positive, I think. There are 58.7% of respondents who consider their professional efficacy as high, and only 16.3% that consider it low. As you can see, the clinically significant depression was reported by 19.6 respondents. And clinically significant anxiety was found in 14.1% of respondents. Depression had a moderate, statistically significant correlation with emotional exhaustion, which was assessed by Spearman coefficient, and weak correlation with cynicism. And there was a weak statistically significant correlation between anxiety and exhaustion as well. Let's go to the conclusion. So burnout symptoms were detected in up to 27.6% of respondents. A statistically significant association between emotional exhaustion and clinical symptoms of depression and anxiety were found. And these results may be used in planning preventive strategies to reduce mental health problems among healthcare workers. So thank you for your attention. Do you have any questions?
Thank you for your presentation. I would like to ask about health workers types. What from which medical, nurses, and others? Difference will be not.
So my population is quite small. I divided healthcare workers in groups. There were medical doctors, actually a few of them, because it's rehabilitation center and there are more functional specialists. There were a lot of functional specialists like physiotherapists and other stuff. Also nurses, and the last group was like other stuff, nurse helpers, etc. There was a little depression was a little bit more prevalent among functional specialists, but I think it's because of the age, because I have found correlation among the age and depression, actually, and age and emotional exhaustion. Because in age group of younger people who completed the survey, depression and anxiety and exhaustion were higher. And these functional specialists, these are younger people, usually physiotherapists in this rehabilitation center are young. So I suppose it's more about age. But the groups were small, so I think it's not very significant yet tested.
And depends on experience of depends more experience, more depression, or
more experience, less depression, actually, in my population.
Thank you.
Thank you for the question.
Thank you for presentation. I have been working in this Maslow questionnaire so long time, and I would like ask you what criteria you used for classification. Is there burnout or not? Have you taken from literature or you find for your own research? Thank you.
Thank you very much for the question. Actually, your question is very actual because when assessing the burnout, I have researched and read the meta-analysis, and I have concluded that almost every one of the researchers use this Maslach burnout scale, like how they choose to use. Actually, I used the cutoff scores, which were used a bit earlier, because I wanted to compare my data with my colleagues' data who assessed it in medical students, and yes, it was convenient. But now I know that the authors of the Maslach burnout survey, they use a bit different classifications. They use like types of burnout, but they have provided formulas which work on a standard. How was it? I'm sorry, the standard curve. And as I have only 98 respondents, my data are not like among the standard curve, so I couldn't use the formulas. If I understood your question correctly.
Present her work of how asthma symptoms are associated with the quality of life among LU-HS students.
Hello, it is really nice to be here, and as a team member I want to present our topic is how asthma symptoms associated with the quality of life among Lithuanian University of Healthy Science students. So our introduction. Asthma is the most common chronic respiratory illness that affects more than 300 million people worldwide, and symptoms are non-specific, but the most common ones include wheezing, shortness of breath, chest tightness, and cough. Difficulties with self-management are associated with reduced quality of life. And this study aim was to evaluate if asthma symptoms have association of quality of life between Lithuanian University of Healthy Science students. And methods, so there were 361 study participants aged between 1941 years old who completed a self-administered anonymous questionnaire. This questionnaire consisted of questions about gender, age, asthma symptoms, and quality of life. There were 6 questions that include current well-being, restriction of daily activities, sleep disorder, fatigue during the day, emotional state, worsened relationship with family members. So there were 24 of participants that had a confirmed diagnosis of asthma, and 337 participants had not a confirmed diagnosis of asthma. So we used chi-square criteria, and the results were statistically reliable when p was less than 0.05, and a statistical analysis was performed by using Microsoft Excel and statistical software SPSS. And results. So let's begin with current well-being. So among those who were confirmed with asthma, there was a statistical significance between the respondents who selected their well-being as bad and respondents who picked their well-being as great. And among those without allergic asthma, there were statistically significantly more respondents who rated their health as excellent than as poor. And moving on restrictions of daily activities. So in statistically significantly confirmed diagnosis of asthma group, we found a greater number of respondents stated that they did not experience restrictions of daily activities. And among those without allergic asthma, there were also statistically significantly more respondents who stated that their complaints did not restrict their daily life, then slightly or severely restrict them. And then sleep disorders, those who had confirmed diagnosis of asthma, there was statistically significant no suffering from sleep disorder. And also among those who did not have confirmed allergic asthma, there were statistically significantly more respondents who stated that they did not experience sleep disorders due to above complaints than slightly. And moving on fatigue during the day. So in statistically significantly confirmed diagnosis of asthma group, no fatigue during the day. And among those who did not have confirmed allergic asthma, there were statistically significantly more respondents who stated that they did not feel tired during the day due to above mentioned complaints than they felt very much. Moving on, Warner's relationship with family members. So in statistically significantly confirmed diagnosis of asthma group, there were no bad relationship with family members, and among those who do not have confirmed allergic asthma, there were statistically significantly more respondents who stated no deterioration of family relationships. And the last, emotional state, no strong correlation was observed about emotional state between different groups. And our conclusions. So our data suggests that diagnosis of asthma is not necessarily related to the reduced quality of life. It could be presumed that the students have enough knowledge about disease and ways to control it. So this is our references, and thank you for your attention.
How you select your respondents and how you distributed questionnaires?
Yes, so we had a questionnaire and we used it university email, and yeah, that's all. We sent to all students of university.
Thank you. My simple question. What was design of your study? It was cross-sectional or case control? Did you find at first these students with the asthma?
No.
It was cross-sectional?
Yes.
But why better to use case control? To find at first the students with diseases and then to take some control group. Do you think it would be better?
Yeah, it would be better. Maybe we would have more students that have confirmed asthma because there was only 24 students, yeah, that were confirmed. So maybe we could find more students that have asthma.
So, according to your results, it seemed that students with asthma, they're healthier and have less problems than students without diseases. How you can explain this? It is more methodological things, or it's real life? And to think that your sample size really represent all students of the university?
No, so that's why we needed more students that have asthma. So maybe that's why there was such results. But maybe those who have asthma can live with it, and yeah, they have that quality of life as we can see.
Also, you need to think about statistical evaluation of such data, because it's from your abstract, it's very difficult to guess what data, how you calculate your data, and those results are significant or not significant. It's very difficult to guess this also from your presentation, so please take this in mind.
And what you not use it standardized quality of life questionnaires SF12, SF36, and
we thought that it would be easier to use only those 6 questions and evaluate everything. But yeah, maybe we needed to take, for example, SFL or Ference, and yeah, there is one more, but I can't remember then.
Thank you.
Thank you for the presentation. I would like to ask you, why did you choose medical students? Do you think that medical students or quality of life with asthma will be different from other students, for example, of technical university or other universities?
Maybe it was interesting for us because we are also medical students, so that's why I think.
For your personal interest.
Yeah.
Thank you.
Thank you again for your presentation. And finally, the last presentation for today in this session will be by Saulius Knystautas, and his topic is comparison of incidents from burns in Lithuania by place of residence, gender, and age.
So hello everyone, my name is Saulius Knystautas. I am a 5th-year medical student, and today I would like to present our thesis, comparison of incidents from burns in Lithuania by place of residence, gender and age in the time period from 2001 to 2019. Introduction. A burn is an injury to the skin or other tissue primarily caused by flame or hot fluids, or due to radiation, radioactivity, electricity, or contact with chemicals. Every day, over 30,000 people suffer new burns worldwide, severe enough to warrant medical attention, equating to an estimated 11 million new burns each year globally. Burn injury cause physical and mental health damage, which leads to worsened quality of life. Burn prevention programs are the most efficient solution to reach significant reductions in the incidence of burns. Burn prevention requires adequate knowledge of the epidemiological characteristics and associated risk factors. So the aim of the study is to analyze changes in incidence of burns in Lithuania by place of residence, gender, age, and their changes in Lithuania in the time period from 2001 to 2019. Methods. A retrospective review of data, age 0+, on incidents from burns, ACD-10 classification codes from T20 to T32 in the time period from 2001 to 2019 was obtained from Hygiene Institute, the health indicators of Lithuania database. Incidence rates from burns by place of residence, gender, and age were calculated 100,000 population. For the assessment of the trends of incidents during 2001 and 2019, joint point regression analysis was applied. Average annual percent change considered statistically significant when P was lower than 0.05. So the results. In the time period from 2001 to 2019, incidence rates from burns increased more rapidly in rural area, on average by 2.19% per year compared to urban area, on average by 1.12 point per year. As we can see in this diagram, incident rates of burns in rural and urban areas comparison, and in urban area the lowest incident rate was in 2009 and the highest incident rate was in 2016. In the rural area the lowest point was in 2011 and the highest point was in 2013. In the time period from 2001 to 2019, incident rate of burns changes were similar in females, on average by 1.65% per year, and males, on average by 1.18% per year. And there also we can see a diagram of incidence rates of burns among females and males. And males and females have the similar incidence rate lower and highest points in 2009 and 2016. According to statistical data from the time period from 2001 to 2019, incident rates increased the most in the age group from 0 to 17 years, on average by 3.68% per year. Incidence of burns increased on average by 1.5% per year in the age group from 18 to 44 years. Incidence rates increased on average by 0.22% per year among adults aged 45 to 64 years. And the incidence rates increased on average by 0.47 per year among adults 65 or older. And this is my conclusions. During the time period from 2001 and 2019, incidents of burns have been increased in rural and urban areas. Incidence rates among females and males were similar. And the highest incidence rates of burns were in the age group from 0 to 17 years. And this is my reference. And now I'm waiting for your questions.
Thank you for presentation. I would like to ask about 2009, 10 years. What caused that in this year we having very small rates of burns, and in 2013-14 very high rates of burns?
Thank you for the question. We have this discussion with my colleagues, but actually, to be honest, none of us know exactly reason, because exactly these years are the similar between the age groups.
And in more young people, we having more.
Yes, and we can explain this by the differences between adults and young people. And the first one is that adult people usually do not go to the hospital when they severe superficial, not hard burns, compared to the children because of parents' effect on that. The second thing is that, for instance, adult people skin is different than young people, and young people, children, usually the burns really more hard compared to young people from hard water stem, for example. And the third reason is the coincidences in home surrounding accidents in children, between children, because it is still more common between children to get in an accident with hot stems and hot fluids.
Thank you.
Did you use hospitalization database only or also primary healthcare data?
It is just data from Institute of Hygiene. We do not done the comparison into the between the hospital data. We did just only in the data with.
So it was data of incidence.
Yes.
It's me. Okay.
Thank you for your questions.
Thank you, Saulis, for wrapping up our session today. Can we please clap? And I would also like to thank all of the presenters one more time for your delightful work today. And next up, it would be really great if we take a 7-minute break while the votes are counted, and then we will come back and announce the winners for today. Hello. So again, I would like to thank the jury for their work today. And now I am really delighted to announce that the winner for today's public health session is the study titled Awareness and Attitude of Women in Kelmė City Towards Primary and Secondary Cervical Cancer Preventions by authors Aistė Ogulevičiūtė, Ieva Armonaitė, Dovilė Danaitė, and Olga Meščerekova. Okay, so the public health session has finished right now, and I would like to thank all of the participants for attending the 6th International Health Sciences Conference, and hopefully it was interesting for you. And now I invite you to join the rest of the conference and come listen to the keynote speaker today, who is Associate Professor Dr. Vincas Urbanas. So thank you for your interest in science, and I also encourage and invite you to take some pictures outside of this auditorium.
Welcome everyone to the 6th International Health Science Conference, Internal Medicine. My name is Yeva and I will be leading the session today. First of all, on the behalf of Student Scientific Society of Lithuania University of Health Sciences, I would like to thank our patrons, Francesius Kabir, Rashem, Medita, Ahmed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that International Health Science Conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health in young science all over the world. Additionally, I would like to thank our reviewers today and today's jury, Professor Rūta Arūnė Bumlytė, Diana Zinkienė, and Rūta Navardauskaitė. We kindly ask jury members to remain at this session until the points are counted and the winner will be announced. Before starting this session, I would like to remind some rules. Today we will hear 6 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the session. The winner will get sponsored awards, gifts from Bioderma, Sapiens, Christomus Bookstore, Orgmed, Gintarinė Vaistinė, Filman, and Medita. Winners will receive their gifts after the session. Moreover, presentations should not last more than 7 minutes, and after that, 3 minutes will be dedicated for questions from the jury and members and listeners. Please note, if your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in the given time frame as well. Moreover, each presenter will receive a certificate that will be sent to the emails after the conference. Do you have any questions? If no, we can start, and best of luck to the presenting authors. So now I would like to invite the first presenter, Monika Šataitė, to give us the first presentation about associations between Helicobacter pylori infection and non-alcoholic fatty liver disease.
Hello everybody, my name is Monika Šataitė and I'm going to present our research, which is called Associations between Helicobacter pylori infection and non-alcoholic fatty liver disease. The relationship between Helicobacter pylori infection and non-alcoholic fatty liver disease is actually a matter of debate, and the results still remain controversial, although a couple of meta-analyses indicate a positive association between these two diseases. By confirming the link, new insights might be provided in the management of non-alcoholic fatty liver disease. And accordingly, the aim of our study was to determine the association between Helicobacter pylori infection and non-alcoholic fatty liver disease. We performed a retrospective study involving 120 patients diagnosed with non-alcoholic fatty liver disease at Kaunas Clinics Department of Gastroenterology in 2020. Inclusion criteria were age more than 18 years old, diagnosis of non-alcoholic fatty liver disease, as other causes of hepatitis were ruled out. We analyzed liver enzymes and total serum bilirubin, body mass index, and as well obtained attenuation parameter and liver stiffness measurements using FibroScan. Helicobacter pylori infection was assessed and patients were grouped according to infectivity. The diagnosis of Helicobacter pylori infection was based on the results of serum anti-HP IgG antibody and histology, which was obtained by biopsy samples taken from gastroendoscopy. Statistical analysis was performed using statistics software. Data significance was evaluated using Mann-Whitney U-test and student t-test. Data differences were considered statistically significant at p less than 0.05. Out of 120 patients with non-alcoholic fatty liver disease, 58 were men and 62 were women. Mean age of the participants was 51.6 years. Helicobacter pylori infection was diagnosed in 1/5 of the patients. And aminotransferases were significantly higher in HPE negative patients, both alanine transaminase ALT and aspartate transaminase AST. The results are shown in the diagrams. And gamma-glutamyl transferase, GGT, and total serum bilirubin were insignificantly higher in HP negative patients. The results are also shown in the diagrams. Alkaline phosphatase, ALP, was similar in both HP negative and HP positive groups. And although average BMI was similar in both groups, being slightly higher in HP positive patients, both groups were obese. But statosis grade and fibrosis stage were insignificantly slightly higher in HP negative patients. I may also add that both groups were in 3rd grade of statosis, which means it was severe statosis, and both groups were in F0 fibrosis stage, which means minimal scarring of the liver, which means actually no fibrosis. And to conclude my presentation, according to our retrospective analysis, there's no connection between non-alcoholic fatty liver disease and Helicobacter pylori infection. This is my reference list, and if you have any questions, please ask, and I will try to answer them. Yes.
Non-alcoholic fatty liver disease, 120.
Yes.
What again?
Yes. There were more patients, but some of them were excluded because they didn't have some of the data. So to make the study more proper, some of them were excluded. So the results wouldn't be. Only with case reports. It was a retrospective study, so only the documents were analyzed.
And have you possibility to work with this FibroScan or also use only data?
Only the data that was described in the documents, in the medical history.
I'm sorry, Professor, can you turn on the microphone?
Okay, thank you.
Thank you.
First of all, thank you. I want to ask you, maybe can you tell me what do you think, why you had significantly or non-significantly increased results, for example, of transaminase in without HP group?
That's a good question, thank you. But actually, it's quite hard to say because when I was doing some research, I was hoping that those results would be higher in HP positive patients. So it was interesting to see that they were the other way around. But why? It's hard to tell. Maybe more research needs to be done on this question.
Okay, thank you.
Thank you for your presentation. So you didn't get any significant correlation, so maybe you predict maybe another factors could be related with Helicobacter pylori. Maybe you analyze but not show for us, so maybe you can.
Well, all of the results show there's no significant difference between these two groups, but actually though it's not there. The study showed that there's no association between Helicobacter pylori infection and non-alcoholic fatty liver disease. It may be as well good results because it doesn't make the disease worse having that infection. So if I answered your question.
Yes, thank you. So a lot of very interesting study, because maybe was any kind or reason why was done gastrofibroscopy, and why is analyzed for this? Maybe was any pain?
The patients that were referred to the gastroenterologist due to increased liver enzymes, where some of them had dyspepsia symptoms, and that's how it was the Helicobacter pylori diagnosed in some of these patients. And I think in the future, maybe some prospect cohort studies need to be done to have more precise results and to get the results of Helicobacter pylori, if it's positive or negative, in all of the patients, not in some that only have the symptoms of dyspepsia.
Thank you, Monica. So now I would like to invite Daniela Janušaitė to present us efficacy of different treatment strategies in patients with hepatocellular carcinoma in Hospital Kauno Klinikos.
Hello, everyone. My name is Daniela Janušaitė. I'm a sixth-year student, and today I'm going to present our thesis, which is called Efficacy of Different Treatment Strategies in Patients with Hepatocellular Carcinoma in Hospital of Lech Kauno Klinikos. The co-authors of this thesis were two other students, Ieva Petkutė and Šarūnas Simonas, and our supervisor was medical doctor Egidijus Morkūnas. Hepatocellular carcinoma is the fifth most common cancer, which has an increasingly high mortality rate worldwide. It is predicted that the incidence of mortality of HCC will significantly increase in the next decade. The aim of our study was to assess the efficacy of different treatment methods in patients with HCC in the Hospital of Lech Kauno Klinikos, and to compare survival times with global BCLC guidelines. So we retrospectively analyzed 105 patients treated in the Hospital of Lech Kauno Klinikos with HCC diagnosis in the time period from 2012 and 2022. Our patients were divided into two groups based on their Barcelona clinic liver cancer stage at the time of the diagnosis. So 39 patients in group A with stages 0 to A, meaning very early and early stages, and 66 patients in group B with stages B, C, and D, meaning intermediate, advanced, and terminal stages. Treatment methods were grouped into four groups. So transarterial embolization, including chemoembolization, systemic treatment method, radical treatment method, including cardiac frequency ablation, tumor resection, and liver transplantation. And the last group was for multiple treatment methods, meaning two or more combined. The outcomes were compared between the two patient groups, so A and B, and the survival times were compared with BCLC guidelines. The normality of the data was assessed with Kolmogorov, Smirnov, and Shapiro-Wilk tests. The descriptive statistics, for descriptive statistics, median values were used. For non-parametric statistic, Mann-Whitney test was performed for a comparison between two groups, and Kruskal-Wallis for more than two groups. And statistical significance was considered p less than 0.05. The most used treatment method was radical in group A and systemic in group B. In both groups, patients survived the longest after receiving multiple treatment methods. So in Group A, patients survived approximately 38.5 months, and in Group B, they survived 23 months. Here on the right hand side, you can see the illustration, which shows how many months patients survived after receiving different treatment methods. So patients treated with radical treatment methods survived 31 months in Group A and 15 months in Group B. Those who underwent transarterial embolization survived 17 months in Group A and 19 months in Group B. And patients who received systemic treatment survived 38 months in Group A and 13 months in Group B. Median survival time in Group A was 30 months, which is shorter than predicted survival time for patients with BCLC 0 and A stages, which is more than 60 months. And patients in Group B survived approximately 17.7 months, which is also shorter than BCLC predictions for patients with B or C stages. And to conclude our topic, multiple treatment methods are the most effective therapeutic strategy with the longest survival time for HCC patients with all BCLC stages from 0 to D. And patients treated with multiple treatment methods survived longer comparing to other treatment methods is because in the early 0 and A stages, treatment usually starts with radical procedures followed by other treatment methods when the disease is progressing, whereas in B, C, and D stages, treatment usually right from the start consists of several treatment methods combined. Here are our references. Thank you for your attention. Maybe you have any questions?
Thank you very much for a nice presentation. And as I understood, it was team who made this study, yeah?
Yes.
5 or 6. So what was your personal input? How you will describe?
In this work, we were 3 students in total, and we tried to divide this work equally. So first of all, we collected the data from the database. We analyzed the results, counted the proportions, etc. Then I personally counted the BCLC stage for all the patients. Then my co-author did the statistics. I didn't do that, but I wrote the whole thesis after all. Yes, so that was my personal input.
Yeah, and you probably in your study group discussed why survival results in our clinic actually to compare to this international, or how to say, was
lower.
A little bit worse. Why?
Yeah, so to answer this question, like a more detailed study must be done because we didn't focus on the reasons why the survival times are lower comparing to global BCLC recommendations, let's say. But we had some thoughts. So, for example, maybe our median, let's say, age of the population, maybe it's a little bit older. Also, patients might have different comorbidities, which weren't analyzed in our studies. And also knowing that the main etiological factor of HCC is associated with hepatitis B, C, and the liver cirrhosis, it might raise a question that maybe it is somehow also associated with social status of the patients. So that's our personal opinion, but as said earlier, it is not based on any science or something.
First of all, thank you. I want to ask you, there was written that you will evaluate efficacy, yes, of different methods. So
Yes.
by the term efficacy, you evaluate only the survival rates?
Survival times, yeah. How many months?
But you didn't evaluate like the size of the tumor after the treatment or something like this? Just the survival?
In this study, no.
Okay. About that, also, there was written that you had 105 patients within 10 years, yes? So I think that usually there's more, yes? So what was your excluding criteria?
Yeah, so at first we had a little bit more patients, but there were a part of patients who got, let's say, symptomatic treatment. So we excluded those patients because we wanted to focus more on the treatment methods that were prescribed, let's say, to treat the disease itself, but not to elevate the symptoms.
Okay, thank you. And last question. I don't know how to ask correctly. I'll try. So why you made two groups? One group only with early stage, and the second group with terminal, advanced, intermediate. So it's like the terminal stage is basically worsen the survival rate. So why not to split into more groups?
So we wanted to split patients. Let's say we wanted to have two basic groups, and yes, maybe terminal stage D, let's say, it has lower survival times, but in our study, patients with BCLC D stage, there were only about 2 or 3, so we didn't want to make a separate group for only 2 patients.
Thank you for your presentation. So maybe you know how long it takes from stage A to stage B, maybe because if we calculate this time and the time from your study, maybe it's the same. So maybe you know how...
Oh, you mean the global survival times? Oh, yes. So for stage... So for stage 0, you mean, to compare? Okay, so for stage 0, the survival rate is more than 5 years, as in 60 months. Oh, and for stage B, I think the rate is the same. We used the references, which is the newest data, but I cannot tell you exactly right now. But I think the survival rate is the same.
So also I would like to ask, you have very huge distribution from about survival from 0 months until 89 months. Maybe if you exclude the outliers, maybe the median of the study maybe will be better. So you try calculate this or not?
Well, no, we didn't do that.
Okay, thank you.
Okay, thank you.
So now I would like to ask Šarūnas Simonas to talk about factors affecting survival time in patients with hepatocellular carcinoma.
So good afternoon, dear jury participants and guests. My name is Šarūnas, and today I will talk about our study about factors affecting survival time in patients with hepatocellular carcinoma. As the name itself describes, this carcinoma is a malignant primary liver cancer. Today, annually, the numbers of patients with this diagnosis are increasing, and also the mortality rate of this cancer has been increasing all over the world. Our study aim was to identify factors that affect the survival time of patients with this cancer, but before they undergo a specific treatment. We analyzed 127 patients retrospectively. We collected data about patients' age and sex, about the concentration of the first time measured alpha fetoprotein levels. And also we checked, calculated child Bach class of liver function. Also we checked the diameter of the largest tumor node and whether the carcinoma was multinodular or non-multinodular. We used Kolmogorov, Smirnov, and Shapiro-Wilk test for testing the normality. We described median values and mean. We also used Mann-Whitney and Kruskal-Wallis tests. Also, we calculated Spearman's correlation coefficient, and there was a statistical significance when p-value was lower than 0.05. So the mean of patient age was approximately 64 years. The majority of patients were male, 77%, and 22.8% were female. Here you can see the difference between the females and male survival time. However, this difference wasn't statistically significant. Here you can see child block classification among patients. The vast majority of patients had class A, which means that their liver function was normal. There were 16% of patients who had class B. Class C was only 8%, and 7% of patients had unknown class. Here you can see differences among child block classifications. The highest survival time was among patients who had class A liver function. And the difference was statistically significant. Here you can see distribution of types of carcinoma. Half of patients had non-multinodular carcinoma, and almost 40% had multinodular, and 10% had unknown number of nodules. Here you can see the differences between the multinodular and non-multinodular. The difference wasn't statistically significant because p-value was exactly 0.05. We found that there is a negative, weak correlation between the diameter of the largest tumor and survival time. The correlation coefficient was minus 0.359. And there wasn't statistically significant correlation between the survival time and first time measured alpha fetoprotein. Here you can see the numbers, and the scatter diagram wasn't linear. So in conclusion, liver function described as child block classification and the size of the largest tumor both affect the survival time of this patient with carcinoma, and they are important for the prognosis. Here are the references, and now the questions.
So your study data and the results, it's a little bit happens because you have correlation, so every researchers like it. So I see that the most patients haven't the nodular in HEPA, so, and you see that a lot of you see the correlation of nodular and survivor, and maybe you know differences how long survive this nodular.
Well, I can't say exactly. We just wanted to know whether there is correlation or no.
Okay, thank you.
Because other studies just they divided tumor in size, whether the tumor is big or small, but there wasn't any correlation trying to do.
Okay. Thank you for the presentation. So, by the identify factors, you didn't used any factors from the anamnesis of the patient. So, for example, which disease caused, like hepatitis or etc. The, I don't know, alcohol consuming in the past. You didn't use these factors, yes? Or?
We tried to find information about the etiology, but there is a lot of cases with unknown etiology, and we can't say whether it's truly idiopathic or because it was written unknown because of political reasons, because problems are in Lithuania with alcoholism, and sometimes doctors they don't write this diagnosis.
Thank you.
Thank you, Sharunas, and whole team. Also, you 4 or 5? Yeah, in your study 4. So, what's your interpretation? Why alpha fetoprotein in serum? Why is this biomarker did not show any correlation?
Because there are a lot of very extreme values. They are not, I wouldn't say that they are outliers, but there is no normal distribution, because the majority of values were approximately 100 times higher than the upper lower limit, but there are a lot of values that were 1,000, 10,000, or even 100,000 times higher than the normal levels.
So next off, I would like to ask Gabriela Cybulskaitė to present her thesis of gastroenteropathic neuroendocrine neoplasm in Lithuania in 2020.
Hello, everyone. I'm Gabriela Cybulskaitė. I'm going to be presenting our analysis of gastrointestinal neuroendocrine neoplasms in Lithuania that we conducted in the National Center of Pathology that is located in Vilnius. And before starting, I want to briefly go over the classification and the terminology that is essential when talking about these neoplasms. And according to the current World Health Organization classification of tumors of the digestive system, the neuroendocrine spectrum is divided into neuroendocrine tumors that are well differentiated, or NETs in short, then into neuroendocrine carcinomas, or NECs, that are always poorly differentiated, and into mixed neuroendocrine, non-neuroendocrine neoplasms, or MNENs in short, that are well or poorly differentiated, because inside they can have both NET or NEC components. And the problem is that the grading of these tumors is constantly changing in search of the best way to group these lesions. And with our annual analysis, we are trying not only to report the rates of specifically gastrointestinal neuroendocrine neoplasms, but also reflect shifts in classification and the terminology, and hoping to further diagnostic improvement. So our aim was to analyze pathology reports of the year 2020 that were made in the National Center of Pathology of Lithuania and summarize the spectrum of gastrointestinal neuroendocrine neoplasms, or NENs in short, with emphasis on their location. And our methods, so we identified and analyzed 209 cases with confirmed lesions of neuroendocrine origin that were diagnosed in our center, and all of the diagnoses were obtained from PATHIS information system using filters for key phrases and disease classification codes, and the descriptive statistics were obtained using Microsoft Excel after manually categorizing the unstructured data. So our results show that out of 209 cases that consisted of neuroendocrine hyperplasia, tumors with partial neuroendocrine differentiation, then NET, NEX, and MENENS. 160 of them were first-time diagnoses, with 152 being NETs and NEX, and 8 being MENENS. And out of these 160, we had 30% that were of pulmonary origin, 40% that were of gastrointestinal origin, 21% originated from other locations, and 9% of cases were metastasis of unknown origin. And we found that gastrointestinal NENs were most prevalent in the stomach, pancreas, and colon. When analyzed by their grade, which can be graded into 3 grades, G1, G2, and G3, going from low grade to high grade, we seen that 53% were G1, 24% were G3, and 23% were intermediate G2 grade. When talking about MENENS, the most common sites for MENENS in gastrointestinal tract were colon and the stomach. And when talking about proliferative index, which is used to determine the grade also because it tells us how fast or slow the cancer cells are proliferating, we have seen that 51% was less than, the index was less than 3%, which means the tumor was low grade. In 27% it was above 20%, which means the tumor was high grade, and in 14% it was intermediate. So what have we seen in our analysis? So the first thing is that the most common gastrointestinal NEN origin sites in Lithuania remain the stomach, the pancreas, and the colon, which we can confirm when compared with our previous year's analysis. The incidence of gastric NENs has increased, though this deviation is likely sporadic and depends on annual local diagnostic approach. And we've seen persistent differences from the most common NEN sites reported in, for example, USA, which is rectum and small intestine when compared to our stomach and pancreas. And we think that it could be an interesting topic for further investigation and leaves room for these poorly understood neuroendocrine neoplasms. This is our references, and thank you.
Thank you for presentation. So neuroendocrine tumor is quite a rare disease.
Yes.
So it's quite a huge range of cases, and it's very interesting, this prevalence of all. And maybe, yes, it is question in advance, maybe not from this your presentation. Maybe you know how many tumors were hormonally active?
Yeah, so in this study, I haven't calculated the hormonally active tumors, but as I did the analysis or part of it myself, not only I couldn't say if there were a lot of them, but also there were not maybe sometimes enough tests in immunohistochemical tests made to evaluate that. So the precise number I don't have, and I didn't calculate.
Thank you for the presentation. What is your thoughts? Why we are having increased incidence of gastric NANS?
Well, I did my research and there isn't any concrete proof for why we have this increased rate, but in the last maybe 30 years, in all the world, the incidence has been increasing, and it has been linked to extensive use of anti-acid medication with the proton pump inhibitors, because it makes the stomach secrete more, or maybe the enterochromaffin cells in the stomach are proliferating because we use a lot of proton pump inhibitors, and therefore it has been linked to that, but there's no concrete.
And in your cases, there was some information about proton pump inhibitors?
No, just only speculations why would, but not.
Okay, thank you.
Thank you. Eva, yeah?
Gabriele.
Gabriele. What is your personal input? You got diagnoses and...
Yes, everything was retrospective. I just got the information without any personal details. There were only pathological diagnoses, and I manually just structured them and made into descriptive statistics and calculated everything.
Yeah. Do you have possibility to participate together with pathologists when they look these materials and to know how they make diagnoses exactly?
Personally, I've been, I made practice into in the Center of Pathology because I'm interested in it, so I've seen how it is done. In some cases when there were some unusual findings, or we just checked it again and checked the with a microscope and everything, so there is a possibility to do that.
Okay, thank you.
Thank you, Gabriela. Now I would like to ask Gerardo Savolionis to give us presentation of analysis of early post-transplant period complications in renal transplant recipients.
Good afternoon. Today I want to present to you our analysis of early post-transplant period complications in renal transplant recipients. So kidney transplantation is a treatment of choice for end-stage kidney disease, and despite the advantages in the risk, despite the advantages in the perioperative care of transplant recipients, the post-transplant complications remain high, and also complications associated with delayed graft function, immunosuppressive therapy, as well as urological and infectious causes can lead to increased morbidity, prolonged stay, or a need for a second surgical procedure. And just to clear things up, a delayed graft function is a need of dialysis within 1 week of transplantation. The aim of our study was to analyze the frequency of complications and delayed graft function in renal transplant recipients during the early post-transplant period, and to determine the factors that could affect the complications and DGF rates. Our study was performed from the start of 2020 until the July 31st of 2021 at Lithuanian University, at the Hospital of Lithuanian University of Health Sciences, Kaunas Clinics. To collect the data, we used a special questionnaire and the Kaunas Clinics electronic medical records system, and for the statistical analysis, we used SPSS version 27, Also, the statistical mean and standard deviation were used. Kolmogorov-Smirnov statistics were used to evaluate sample normality. To compare different groups, we used students' t-test and Mann-Whitney U-test. And logistic regression analysis has been conducted to determine the odds ratios for appearing of delayed graft function and other early complications. And significant values were considered when P was below 0.05. Our study population consisted of a total of 59 kidney recipients, 23 of whom were women and 36 men, with the mean age of 49.9, with a standard deviation of 12.9 years. Our youngest recipient was 21 years old, meanwhile our oldest was 70. 62.7% of all our recipients suffered some kind of early post-transplant complications. And to further divide them into groups, the most common cause of complications were infectious complications, and these were mostly wound infections as well as and also there was some cases of pneumonia, sepsis, and other infectious complications. The second biggest groups is complications of immunosuppression, and the third biggest group was lymphatic system complications with 10.2%, and these included such complications as lymphocele and lymphoria. And also there are other complications such as hematoma, urine leakage, and acute rejection. In our study, we found out that women were more likely to experience early post-transplant complications when compared to men. In our population, 82.6% of women suffered some kind of early post-transplant complications when compared to men, of whom only half did. Not only that, women were also more likely to experience infectious complications specifically, with 69.6%, while only a third of men suffered from them. Just a little bit more than half of our population experienced delayed graft function. And we have found out that on average, patients who had a delayed graft function had a higher BMI than those who didn't. So we recognized an independent prognostic factor for DGF. So when BMI was higher than 25, it increased the risk of developing delayed graft function by 3.6 times. And to conclude it all, 62.7% of our patients suffered from early post-transplant complications, and these were most commonly infectious complications. Women were more likely to experience post-transplant and infectious complications when compared to men, and more than half of all our patients had a delayed graft function, and it was more commonly seen among people who were overweight. And these are our references, so you can now ask questions.
Thank you for presentation. Kidney transplantation, we do more and more every year, but looking to results, what you present, it looks that we have a lot of problems. Yeah? But infection complication, actually, mainly, there are not wound infection. Usually it's urinary tract infection.
Yeah, I want to say,
urinary
in our
tract.
study, the main complication was urinary tract, and the second one.
Do you know why? Why there are, it's not only in our center, it's usual experience with high rate of urinary tract infection. Usually it's not severe, sometimes without symptoms. Why it's so spread in in these patients?
Well, we think it has to do with the fact that surgery in itself produces a risk of some kind of infectious complications. And to add to that, transplant recipients also must undergo immunosuppressive treatment, which also increases the risk of infection.
Yeah, you are right. Immunosuppression, of course, leads to infection. But all of them, they have catheter in the urine.
Yeah,
and for 5 at least days, all of them have stent in transplant kidney.
Yeah.
This also is very important explanation why such, And delayed graft function, it's traditional, it's around 30% if to look to other centers, and here I was surprised, even 50%. Yeah, but delayed graft function, it doesn't mean that it's very bad. It means that the kidney will start work, but a little bit later. So it's not catastrophe. Yeah.
Thank you.
Thank you for presentation. Can you say why do you think you have a high? Why we are having connection between a higher BMI and that increased complications for delayed graft function? Yes.
I think it has a lot to do with the fact that people with higher BMI, on average, also have more comorbidities, and it has to do with that. But I think there needs to be further research. Why exactly did this? Why exactly being overweight was such a factor for developing delayed graft function?
Okay, thank you.
Thank you for presentation. So I would like to ask, maybe you got any correlations between age and infections or?
No, we actually did do research about that, but we found no correlations between age groups or between HLA mismatch, and also, yeah, I think that's about it.
Thank you.
Thank you.
So next presenter will be Vita Karpavičiūtė, and she will present via Zoom, yes? So I leave this on or what? Okay.
Hepatitis B virus and its primary prevention. A study shows a full course of hepatitis B virus vaccination provides protection for at least 15 years, and the majority of adults are able to recover spontaneously after infection. However, despite decades of hepatitis B virus vaccination and effective antiviral drugs use, approximately 250 million people remain infected worldwide. The spread of the virus may be facilitated by asymptomatic course of a disease in the majority of adults, and it is also known that hepatitis B virus can survive outside the body for at least 7 days. So prevention and management of hepatitis B virus for all health sciences students before starting practical work is one of the infection control strategy. So the aim of our study was to assess and compare the knowledge of students from different faculties about hepatitis B virus and its prevention. We used the original anonymous survey. Considering the highest risk of blood-borne infection in the future profession, it was decided to include students from 3 faculties, the Faculty of Dentistry, Nursing, and Medicine. We used SPSS Statistics version 25 for data analysis. A total of 149 students answered the questions, and here you can see the groups. The first question was, how long can hepatitis B virus survive on the surface? The correct answer is green, and as you see, the majority of students chose incorrect. The half of students said that hepatitis B virus are viable on surface for up to 24 hours, and 1/3 thought that it can survive for 3 days, and only 19% chose correct answer. The next question was about asymptomatic course of disease. The half of students were under the mistaken belief that a person with hepatitis B virus infection is more likely to experience some symptoms than to have asymptomatic course of a disease. And we found no significant difference between faculties. The next question was about spontaneous recovery. Only 16% of students chose correct, and 84% of students thought that spontaneous recovery after hepatitis B virus infection is not common. So also half of students incorrectly believed that the full course of the vaccine always provides protection for life. However, the majority of students in all faculties rated the risk of hepatitis B virus in their future occupation as high, and agreed that it is recommended to be vaccinated with hepatitis B vaccine or know their immunological status before starting practical work. We also asked students about information received during the study years. Students from medicine faculty said that they get enough information, however, much was forgotten, while other students from Faculty of Dentistry and Nursing stated that they received little or no information at all. So the result of this study show no significant difference in students' knowledge of hepatitis B virus between faculties. However, the information received during the study year is insufficient, especially for students for the Faculty of Dentistry and Nursing. And here is my references, and now I'm open for your questions.
Hello, thank you for your presentation. So very interesting survey. So my question is, the students know or not all know what they should do vaccinate or something else, but maybe my question is, they know or not what they should to do if incident happens. So for example, they inject any needles or something else. So it is institution who what regulate this.
Yeah, I see your point. We also had asked students about post-exposition prophylaxis, and it was our next thesis or study. This part was only about hepatitis B virus, and our part was about post-exposition prophylaxis.
Okay, thank you.
Thank you for the presentation. I want to know what's your opinion, what we need to change in our studies, or what you will add to make for students better know about hepatitis B, because the results is not very good.
Well, the main problem is in Faculty of Dentistry and Nursing, because students state that they don't receive any information at all. So from my experience, I know that in medical students, we we receive quite enough information. Maybe not for everyone it is enough, maybe. And it's quite tricky question because maybe in study program we have to include more hours for infection control.
Thank you, I agree. Thank you.
Yeah, I also want to add the same point that it will be good that after your study you will find some solution how to improve knowledge of our students. Did you give correct answers later, or they stay with their answers and that's all?
Can you repeat? I'm not sure if I understood.
Yeah, you gave questionnaires, got incorrect answers, but later, did you present it to them the correct answers? Or they stay without correct answers at all?
We was thinking about this, but we were not sure how to do this, so unfortunately we didn't.
Yeah, it's okay, just for future, because you show that we need to improve this knowledge. We have to disseminate correct knowledge, yeah? Okay, thank you.
So now I would like to thank all the presenters for their presentations and for the jury for their questions. And let's take a 7-minute break while all the scores are counted. And right after the break, we will announce the winners.
paskelbsim, bet norėtume diskusijos su komisijos nariais. Čia greitai. Dabar kaip privalomumas mums yra pateiktas BMD, tai tų paprastų žiūrėkit, mes nebeužsiimam. O BMD kaip privalomumas. Aš jeigu priskiriau, aš neprologas mokslas. O iš tos endokrinologas gal tik du. Galėjo, bet tik pirmą motyvą prisipažinau, kad visgi aš noriu endokrinologas.
I would like to thank the jury for their work. Thus, after counting all of the jury points, I'm delighted to announce that the winner of this session is Gabriela Cibulskaitė with her team, Rokas Tulpinas and Ugnius Mitskys. So congratulations, you can come to take your presents and your certificate. We can. So the internal medicine session has finished, and I would like to thank all of the participants for attending. And science conference, hopefully it was interesting. And now I invite you to join the rest of the conference and come listen to the keynote speaker today. So thank you all for your interest in science, and have a good day.